this opportunity. Part of this CME on the current therapeutic approaches to type 2 diabetes. So I have been given an interesting topic that is master switch in type 2 diabetes management. So as we all know, type 2 diabetes is a disease of multiple factors. It has multiple pathophysiological factors. It has multiple genetic factors. And we have multiple treatment options also for type 2 diabetes. So through this talk, I'll just try to give a brief overview of the current guidelines regarding type 2 diabetes, or the latest guidelines, and what are the changes. And we'll look at a few important anti-diabetic agents that we have and how we go about selecting the agent for our patients. Yes, this is my disclosure. And so we'll talk briefly about the type 2 diabetes incidence and pathophysiology, and I'll give a brief summary of the recent American Diabetes Association guidelines, and we'll look at the role of certain important anti-diabetic agents that we have today, that is SGLT2 inhibitors, GLP-1 agonists, and the DPP-4 inhibitors. I'll present a few case scenarios, and also we'll look at the present position for some of our older molecules, that is the thiazolidinediones and sulfonylureas, and how they are useful currently. And we'll look at the important guidelines and how they compare to each other. I will not focus much on insulin, as I think we have a couple of other talks coming up regarding the insulins and the technologies related to type 2 diabetes. So type 2 diabetes, of course, as we know, is a global pandemic and is an important independent risk factor for multiple complications, and the incidence is increasing year on year. So we all are aware patients of type 2 diabetes divided macrovascular and microvascular. So macrovascular, of course, is mainly the cardiovascular disease. It can be myocardial infarction, stroke, or peripheral arterial disease, and the microvascular complications, that is the nephropathy, retinopathy, and neuropathy. So again, the numbers of type 2 diabetes has been projected to increase in the next 10 to 15 years. And as we all know, India is also called as the diabetes capital of the world and has one of the highest incidences of type 2 diabetes. So diabetes is, as I told you, it's a multifactorial disease, and it's a progressive disease. So initially it starts off as a pre-diabetes, that it may be an impaired fasting glucose or an impaired glucose tolerance when there is an increase in the insulin resistance. But the insulin level and the beta cell function are preserved, and so the blood glucose level still remains normal. But as the duration of the disease progresses, the insulin level and the beta cell function progressively starts falling down, and the insulin resistance increases, and this leads to further increases in the fasting and the postprandial plasma glucose. And this is the onset, this leads to the onset of type 2 diabetes. So as we can see in this study, normally in patients without type 2 diabetes, the insulin secretion rate can increase in response to an increase in blood glucose. And this helps to maintain the plasma glucose levels. So as we can see here, as the plasma glucose levels are increasing, the insulin secretion is also increasing in normal glucose tolerance patients, or even in an impaired glucose tolerance patient. But in patients with type 2 diabetes, this increase in insulin secretion cannot happen, and hence the plasma glucose level starts to get elevated. So this is the famous ominous octet given by DeFronzo in 2009. So he proposed that there are multiple pathophysiological factors affecting type 2, leading to type 2 diabetes. And this is important to know, because when we know the multiple factors which can lead to type 2 diabetes, we also have multiple targets for treatment and for development of newer anti-diabetic medications. So decreased insulin secretion from pancreas is definitely a pathophysiological factor, and also there is increased glucagon secretion from alpha cells. The liver is involved, there is increased hepatic glucose production. There's also some neurotransmitter dysfunction, decreased incretin effect, and the kidneys are also proposed to be involved by increased glucose reabsorption. So now we'll see what are the different medications that we have which focus on the different targets and help to treat the diabetes. So biguanides, that is the metformin, we know is one of the oldest anti-diabetic agents, basically increases glucose uptake and decreases the hepatic glucose production. Similarly, thiazolidinediones such as pioglitazone, rosiglitazone, again act at the peripheral level. So they basically improve the insulin sensitivity at the level of skeletal muscle and adipose tissue, decrease lipolysis, and increase the glucose uptake. Then we have alpha glucosidase inhibitors such as voglibose, which delays intestinal carbohydrate absorption, and sulfonylureas, again one of the most frequently used agents, which basically increases insulin secretion from the pancreatic beta cells. And the glinides again act in a similar way. And so then we come to some of the newer anti-diabetic medications which have been developed in the last few years. So GLP-1 analogs are a very interesting medication. They basically improve the pancreatic islet glucose sensing, they slow the gastric emptying and improve the satiety. And similarly, DPP-4 inhibitors basically increase the GLP-1 action by inhibiting the DPP-4 enzyme. And again, they increase the incretin effect. And we again, another new compound is the SGLT2 inhibitors. So they basically act at the level of the kidneys by inhibiting the renal glucose reabsorption. So now we'll briefly look at the ADA 2022 guidelines. I'll just give a brief summary and then we'll go into the individual components. So this is the brief look at the guidelines. So according to the recent ADA 2022 guidelines, again, the first line treatment for type 2 diabetes still remains metformin and of course the comprehensive lifestyle modification. So now the most important change in the last 3-4 years in these guidelines is that the first thing that we need to see when we decide about a treatment for type 2 diabetes in any patient is whether patient has any atherosclerotic cardiovascular disease or any indicators of high risk for atherosclerotic cardiovascular disease, or heart failure, or for chronic kidney disease. So these are the 3 most important factors that we need to initially look at whenever we have a patient with type 2 diabetes and we are deciding on what is the treatment to be given. So if the treatment is basically divided into these 2 parts. If the patient has any of these, or if he doesn't have, then we look at a few other things. I'll come to them individually. So this change has happened in the last say 10 years since the cardiovascular outcome trials started giving some interesting results for certain molecules. So the earlier agents, we never had any definite cardiovascular benefit with any of the medications, whether it was sulfonylureas or thiazolidinediones. But since the introduction of SGLT2 inhibitors and GLP-1 agonists, they both have shown significant benefit regarding cardiovascular outcomes, that is myocardial infarction or stroke or hospitalization for heart failure. And so this has led to a paradigm shift in the guidelines, in the whether it's ADA guidelines or the European guidelines in the last 2-3 years. So we must consider and the atherosclerotic cardiovascular burden. And why is this so? Because still the major cause of mortality in patients with diabetes is the cardiovascular disease. Of course, preventing microvascular complications is very important. And there are a few other causes of mortality, but cardiovascular disease comprises 70% of the mortality. So as we all know, every 1% reduction in A1C will lead to some reduction in diabetes-related death, and also significant reduction in the microvascular complications and the peripheral vascular disease. As regards to the macrovascular complications, the reduction in A1C is important, but we also must choose certain agents which have shown to have definite benefit for the cardiovascular outcomes. So as I already told, cardiovascular disease is the major cause of death and disability, and so prevention of major cardiovascular outcomes such as MI and non-fatal stroke and cardiovascular death has become the most important factor now among people with diabetes, and that has to be the first concern when we are choosing an anti-diabetic agent. So now we'll look at this arm of the guidelines, that is the presence of atherosclerotic cardiovascular disease or heart failure and CKD. So if there is a patient has any atherosclerotic cardiovascular disease, that is MI or unstable angina or a stroke, or he has indicators of high risk, then we must choose either an SGLT2 inhibitor or a GLP-1 receptor agonist with a proven cardiovascular disease benefit. So this has to be incorporated in the treatment along with metformin. If the patient has any heart failure, then SGLT2 inhibitors are the preferred agents, because they have shown significant benefit in reducing the hospitalization for heart failure. And again, if the patient has any CKD with EGFR between 30 to 60, if he has albuminuria or even without albuminuria, again, SGLT2 inhibitors have shown slightly higher evidence of renal protection, reducing the progression of albuminuria and reducing CKD progression. And even GLP-1 receptor agonists in a few recent trials have shown benefit. So what are these, as I already mentioned, patients with atherosclerotic cardiovascular disease are indicators of high risk. So what is this high risk? How do we classify the risk in our OPD, in our daily practice? So what we have to remember is all the patients that we see with type 2 diabetes in our OPD practice are already at a moderate risk for cardiovascular disease. This is true for any patient with type 2 diabetes who does not have any other risk factors. So if a person has a diabetes duration of more than 10 years and he has any other additional risk factor, so additional risk factors can be age more than 50 years, presence of hypertension or dyslipidemia, smoking and obesity. So if there is any other additional risk factor, then definitely it becomes at a high risk for cardiovascular disease. And very high risk is those who have any established cardiovascular disease, or there is any other target organ damage such as retinopathy or proteinuria or a left ventricular hypertrophy. Or he has 3 or more other major risk factors of age and hypertension and dyslipidemia or smoking. So now we'll briefly look at the SGLT2 inhibitor, since this is now a very prominent, plays a prominent role in the ADA guidelines. So we look at a few scenarios on how to use the SGLT2 inhibitors. So what are these SGLT2 inhibitors? So SGLT2, the sodium glucose linked transporter, is the predominant transporter which is responsible for reabsorption of glucose in the S1 segment of the proximal tubule. So 90% of the glucose reabsorption occurs through the SGLT2, and SGLT1 plays a minor role of around 10% reabsorption. So this is the normal process, and because of this major glucose reabsorption, the glucose excretion is almost negligible in a normal individual. So how do these SGLT2 inhibitors act? The SGLT2 inhibitors basically blocks this SGLT2 and hence will reduce the renal glucose reabsorption. So they increase the urinary glucose excretion and has multiple other proposed mechanisms by which they bring about the reduction in A1C and also the cardiovascular benefits. So an important thing to remember regarding SGLT2 inhibitors is that the mechanism of action is completely independent of insulin secretion or action. So this is a very unique molecule because all the other anti-diabetic agents, whether it's metformin or pioglitazone, DPP4, sulfonylureas, all of them require insulin for their action. They potentiate insulin action, or they potentiate insulin secretion, or they increase the incretin effect. Whereas SGLT2 is the only molecule which acts at the level of kidney, and it does not affect the insulin in any way. It just blocks the renal glucose reabsorption. And this gives rise to certain unique benefits for SGLT2 inhibitors also. These can be even used in a very late stage of type 2 diabetes when the insulin secretion is very negligible, and many of the other oral anti-diabetic agents are not very effective, but SGLT2 inhibitors can be effective even at that time. So what are the major SGLT2 inhibitors we have? We have the canagliflozin, dapagliflozin, and the empagliflozin. Of course, there are a couple of other newer ones also now available, that is remogliflozin, ertugliflozin, but we have the majority of data that we have are for molecules. So canagliflozin is available as 100 and 300 mg, and the recommended dose to get a CV benefit is actually 100 mg daily. And dapagliflozin is available as 5 and 10, and empagliflozin as 10 and 25. So even 10 mg of empagliflozin is supposed to give the cardiovascular benefit. Of course, these require certain dose modifications with regard to GFR, and both dapagliflozin and empagliflozin as of now are not really recommended if the eGFR is less than 45. And even for canagliflozin up to eGFR 30, we can consider the use at a 100 mg dose, but less than 30 use is still not recommended. Though in certain trials like the Credence trial, canagliflozin was used up to eGFR of 15 ml. So basically the glycemic efficacy reduces as the eGFR reduces. But of course, it is proposed that the renal protective and cardiovascular protective effects are still possible, even at a lower eGFR. Sorry. Okay. So, so what are the considerations for drug initiation and monitoring in patients who are starting an SGLT2 inhibitor with a demonstrable CV benefit? So there are certain important things we must remember when we are starting a patient on SGLT2 inhibitors. The genital mycotic infections, and we must emphasize on the importance of genital hygiene. Genital mycotic infections are quite common with SGLT2 inhibitors, especially in the initial few weeks of usage. And we must advise the patients to have adequate fluid intake to reduce this risk. And of course, we must also avoid hypovolemia. And if the patient is on some diuretics, we will have to consider reducing the dose of diuretics. And we may also have to slightly reduce the dose of insulin or sulfonylureas if the patient is already on them. And also, one of the rarer side effects is the occurrence of euglycemic diabetic ketoacidosis. Can happen, especially in certain patients. And so we must warn the patients regarding the symptoms of DKA, such as nausea, abdominal pain, or vomiting. and also a rare little increase in the risk for foot amputations was seen in the earlier trials with canagliflozin. So we must educate the patients regarding foot care also in these patients. So I will just look briefly at a certain case scenario and how we can use the SGLT2 inhibitors. So we have a 45-year-old male who has type 2 diabetes for 4 years. He already has hypertension and dyslipidemia. He's on treatment for it, and he has a BMI of 30.52. He's already on treatment with metformin and DPP4 statin, and also an ARB. And his HbA1c is still not at the target. It's around 7.8% with an LDL cholesterol of 98. So what are the important things here that we need to look at? The first thing, of course, the HbA1c is still not at target. He needs better control of the HbA1c. The next important thing we must look at is the cardiovascular risk. So he has 3 major cardiovascular risk factors. That is, he has hypertension, dyslipidemia, and obesity. So he automatically falls into a high cardiovascular risk patient according to the ESC guidelines. So in such a scenario, what must be the ideal next choice of treatment? So he's already on metformin, DPP4, HbA1c not at target, and high cardiovascular risk. So we must consider an SGLT2 inhibitor or a GLP-1 agonist. Now, again, GLP-1 agonist is a good choice, but we must remember that cost-wise, it is much more expensive still compared to an SGLT2 inhibitor, and patients may not be very much willing for an injectable therapy. So in most cases, in such patient, SGLT2 inhibitor is an ideal choice. It can be empagliflozin, dapagliflozin, or canagliflozin for this patient. But of course, we must initiate and educate the patient when we initiate the SGLT2 inhibitor regarding genital mycotic infections, and also appropriately adjust the dose of sulfonylureas and insulin. So now we'll look at another interesting newer molecule for type 2 diabetes, that is a GLP-1 agonist. So we have different GLP-1 receptor agonists. It can be human GLP-1 based therapies or exendin based therapies. The exendin based therapies are exenatide and the lixisenatide. They were initially available as a daily dose, but now even we do have a weekly exenatide also. And the human GLP-1 are the dulaglutide, liraglutide, and the semaglutide. The dulaglutide and semaglutide is available as a weekly injection. Liraglutide is given as a once daily injection. And now also we have a oral semaglutide, which is coming recently, which is the only oral GLP-1 receptor agonist, and this is also a big change now. So, as I mentioned, dulaglutide usually is given as 0.75 milligram per week and then titrated to the maximal dose, and liraglutide at 0.6 and semaglutide as 0.25 up to 1 mg. So it's important to remember that all GLP-1 receptor agonists, we must start at a low dose and gradually up titrate to the maximal dose. This is mainly because of the severe gastrointestinal side effects that we commonly see with these GLP-1 agonists. Now, as I told, we also have got a oral GLP-1 receptor agonist. So it's always more difficult to develop oral peptide-based drugs because of the degradation in the stomach due to the low pH and the proteolytic enzymes, and also because of the limited permeability across the GI epithelium. So that's why we don't have many oral peptide-based drugs. So semaglutide is the first oral GLP-1 agonist that we now have. So in this, basically, they added an absorption enhancer called the sodium aminocaprylate, which basically increases the bioavailability of the oral administration. So absorption of the semaglutide always requires a co-formulation with this compound, and this basically causes local increase in pH and leads to higher solubility and protection from proteolytic degradation. So as I already told, it has a long half-life of almost 1 week, and it's the only oral GLP-1 agonist. Let's skip this. So now again, we must educate the patients, and there are certain considerations we have to give when we are starting a GLP-1 agonist. So again, GLP-1 receptor agonists are quite effective agents. So when we start a new agent, we must instruct the patients to closely monitor glucose at home for the first 4 weeks of therapy. And we must consider discontinuing any sulfonylurea or meglitinides. If the patient is on insulin, we must also consider reducing the total daily dose by up to 20%. And another important thing to note is that we must discontinue any DPP-4 inhibitors because patients commonly are on metformin and DPP-4 inhibitors when they see us. So when we are starting GLP-1 agonists, we must stop the DPP-4 inhibitor and initiate the GLP-1 agonists. So nausea and GI side effects are very common. We must recommend small portion sizes, and we must start at the lowest dose and gradually up titrate towards the goal doses. And also we must recommend eye examinations before starting therapy if not done recently. There is a slightly increased signal for retinopathy complications in a few trials with semaglutide and dulaglutide. And also we must consider avoiding it in patients who have severe diabetic gastroparesis or an active gallbladder disease where it may severely increase the gastrointestinal complications. So I'll just give a brief another case scenario where the GLP-1 receptor agonist, how to use it. So suppose we have a 48-year-old female patient who has type 2 diabetes for 6 years. She has hypertension and dyslipidemia, already on treatment with a high BMI of 34.5. And she is on metformin and an SGLT2 inhibitor also, and she's on statins and appropriate antihypertensives. Still, her HbA1c is not at goal. Her HbA1c is 8.5%. So what do we have here? So a patient whose HbA1c is still high. She has high cardiovascular risk with 3 risk factors. She has moderate obesity also. So what should be the ideal next choice for this patient? She's already on metformin and SGLT2 inhibitor. So can we consider DPP-4 inhibitors? Yes, definitely we can consider them, but DPP-4 inhibitors are basically weight neutral. They do not have any weight loss effect. Sulfonylureas, thiazolidinediones, basically both of them can cause weight gain. So this patient already has a BMI of 34. So we must be a little more careful when we are initiating sulfonylureas or thiazolidinediones. So ideally for this patient, the best agent would be starting a GLP-1 agonist. It can be a daily injection or the weekly ones. Semaglutide, dulaglutide are the best choices because it's easier to convince the patient in clinic to take a weekly injection than to take a daily injection. And they are very effective for the glycemic control and for producing a good weight loss. And also they have significant cardiovascular benefit. So in such scenarios, GLP-1 agonists should definitely be considered. So now, as we already saw, both SGLT2 inhibitors, GLP-1 receptor agonists are both almost the first line that we have to consider when the patient has high risk for a cardiovascular disease. So what are the few differences between SGLT2 and GLP-1 receptor agonists, and like in what situations is one agent preferred more than the other? So with regards to major adverse cardiovascular outcome prevention, both SGLT2 and GLP-1 have shown similar benefits in most of the trials. With regard to heart failure prevention, SGLT2 inhibitors definitely have the more evidence and should be the first choice. With regard to weight loss, SGLT2 inhibitors also cause a mild weight loss, but GLP-1 receptor agonists are definitely more effective if weight loss is a major consideration along with glycemic control. And with regards to renal disease progression or prevention, again, SGLT2 inhibitors have slightly more data and more benefit in most of the trials, though GLP-1 agonists have also shown good benefit. And these are some of the important contraindications or cautions that we may have to consider also. So if the patient has gallbladder disease or gastroparesis or history of medullary thyroid carcinoma or a proliferative retinopathy, then we must be cautious about using GLP-1 agonists. Whereas if the patient has recurrent genital candidiasis or a history of DKA or a history of severe foot disease such as prior amputation or active foot ulcers or peripheral arterial disease, then we must be cautious regarding using SGLT2 inhibitors. So now we'll look at the other arm of the ADA guidelines. So if the patient doesn't have any atherosclerotic cardiovascular disease or CKD or heart failure, so then we must look at few other important factors. So one of the most important one is the need to minimize hypoglycemia. So hypoglycemia is an unpleasant complication which we want to avoid. So then we can consider few other agents. We can consider GLP-1 and SGLT2, but again, if the cost and considering all those things, so DPP-4 inhibitors becomes a very useful molecule. So DPP-4 inhibitors, briefly, it can be sitagliptin, vildagliptin, linagliptin, or teneligliptin, which basically inhibits the DPP-4 enzymes and restores the concentration of the incretin hormones. And they are quite effective. They lower HbA1c by about 0.5 to 0.8%. And the benefit is they are very well tolerated. They are weight neutral and low risk of hypoglycemia. So the gliptins, the most important thing is they are weight neutral. They have excellent safety profile, can be given in most of the patients without any side effects, whether it's gastrointestinal or genitourinary infections or any other side effects are very rare, and they have very low risk for hypoglycemia. And the cost is also lesser compared to SGLT2 or the GLP-1 agonist. Now, what about the cardiovascular safety? So as we know now, for all molecules, we must consider the cardiovascular efficacy or safety. So both sitagliptin and linagliptin in the major cardiovascular trials, that is TCOS and the Carmelina, they have been shown to be cardiovascular neutral. They do not have any specific cardiovascular benefit like SGLT2 or GLP-1 agonists, but they are cardiovascular neutral. Whereas saxagliptin has shown slightly increased safety, has shown a safety signal regarding increased risk for heart failure. So it has been now recommended to avoid in patients with heart failure. Even alogliptin showed a slightly increased trend towards heart failure. So we must be careful with these two compounds. What are the few other safety concerns we may have? Skin reactions have been seen in a few trials with sitagliptin and vildagliptin. Bullous pemphigoid is a rare side effect with vildagliptin, and mild GI effects and arthralgias may be seen. And pancreatitis and pancreatic CA in the few initial trials, DPP-4 inhibition and were shown to have an increased incidence of acute pancreatitis. but most of the other meta-analysis now have shown a low risk for acute pancreatitis, and none of the recent trials have shown any increased incidence for pancreatitis and pancreatic CA. Also, again, we have inconclusive evidence. But of course, we must stop these agents if in patients with pancreatitis, and we must avoid it in patients who have any history of pancreatitis. So what about the renal safety of the gliptins? So again, most of these agents require a little dose adjustment when the EGFR is lesser. So with EGFR of less than 50, alogliptin, sitagliptin, saxagliptin all require the doses to be reduced. Only linagliptin is completely safe with regard to the renal aspect, and even with the EGFR of less than 30, it can be given safely. And hepatic safety is also good, though vildagliptin, alogliptin have been associated with rare cases of hepatic failure. So it's recommended to monitor liver function tests in the first year after starting with the gliptins, and we must avoid the gliptins if AST ALT is elevated significantly more than the upper limit of normal. Now we look at another aspect. So minimizing hypoglycemia is one major thing. The other major thing that we commonly see in clinical practice in most places is the cost issue. So we must always remember from the patient point of view that type 2 diabetes is a lifelong treatment. It requires lifelong compliance and adherence to treatment. And it is not only about starting a certain agent and continuing it for 3 months or 6 months, but none of these agents are beneficial unless they are taken for a prolonged period of time. So we must always factor in the cost issue whenever we are selecting an agent. If the patient can really afford the agent, if he is willing to continue the medication, because unless there is any consistent adherence to the medication, then the effectiveness is already lost. So considering the cost, sulfonylureas and thiazolidinediones are one of the two of the cheapest agents that we have, along with metformin, of course. So definitely when if the HbA1c is still above target, they can be considered as third line or fourth line therapy, and also second line therapy if the patient does not have any atherosclerotic cardiovascular disease. So some of the later generation sulfonylureas have been shown to have low risk for hypoglycemia. And also there is a recent trial, the Carmelina study has shown that sulfonylureas have similar cardiovascular safety to DPP-4 inhibitors. I'll come to that shortly. So how do the thiazolidinediones, that is pioglitazone, rosiglitazone, how do they act? So they are basically true insulin sensitizers, which increases insulin sensitivity at the level of muscle, adipose tissue, and the liver. So they increase glucose uptake and increase the free fatty acid uptake. And they have also shown to reduce macrovascular risk in many studies. They have shown to have a 47% reduced risk of secondary stroke and MI also. So they provide good durable HbA1c reduction and decrease insulin resistance in periphery and liver, and reduce the incidence of type 2 diabetes also, and also have certain benefits on cardiovascular risk factors. Some of the risks for pioglitazone, of course, is that it can cause mild weight gain, it can cause fluid retention. So it is contraindicated in patients with heart failure, and also in patients who have retinopathy with macular edema, we must avoid pioglitazone. So coming to sulfonylureas, we have the first generation sulfonylureas, now it's not available. So the second generation, we have glimepiride, gliclazide, glipizide, and glibenclamide. Some of them are intermediate acting. Some, like glipizide, are short acting sulfonylureas. Even gliclazide has an intermediate duration of action. So as I told regarding the cardiovascular safety, the recent trials, both Carolina and Carmelina, have shown a non-inferiority of glimepiride compared to the placebo and linagliptin with regard to the major cardiovascular outcomes. And this is a very good news for all of us. So what is the position of sulfonylureas in the recent guidelines? So according to ADA, as a third line therapy in people with diabetes and atherosclerotic cardiovascular disease or CKD, following failure of SGLT2 or GLP-1 for glycemic control, we can add a sulfonylurea. And even as a second line option, when the cost of treatment is a major factor and if there is no risk for atherosclerotic cardiovascular disease or heart failure. So newer sulfonylureas have been associated with lesser adverse events of hypoglycemia and cardiovascular toxicity. So we look at one more case scenario before I end. So this is a 37-year-old male, suppose is a newly detected type 2 diabetes on evaluation for a genital infection or a balanoposthitis. Was found to have high GRBS and high HbA1c of 8.8. He does not have any other comorbidities and has a relatively normal BMI of 24. So what are the treatment options for him? So as I told you, he has a moderate cardiovascular risk. So any patient with type 2 diabetes already has a moderate cardiovascular risk, but not at a high risk. And he's a young patient, so low risk of hypoglycemia, and his BMI is fairly normal. So what will be the ideal choice of treatment for him? Metformin along with lifestyle definitely is the first line. We must start it, but considering his high HbA1c and the GRBS and the genital infection, he ideally requires to be started on a dual therapy at the least in the initial stages. So either DPP4 inhibitor or a sulfonylurea is an ideal choice for this patient, and especially if the cost is any concern, then sulfonylurea along with metformin is a very useful treatment option for such patients. So for him, SGLT2 inhibitor in the initial stage is not an ideal choice because he already has a genital infection. So when there is high hyperglycemia and if we start an SGLT2, his genital infection is going to worsen. So at least for the initial few months, we must treat his infection and glycemia and then consider an SGLT2 inhibitor. So we'll just briefly look at the comparison between the recent guidelines, whether it was the ADA and the ESC, European Society for Cardiology guidelines, and the EASD guidelines. So in most guidelines, still the metformin is considered as a first-line drug therapy, but interestingly in the European Society of Cardiology guidelines, they have now said that metformin is not necessarily considered as first-line therapy. And the next important aspect is whether the atherosclerotic cardiovascular disease predominates or heart failure or CKD predominates, then we must consider the SGLT2 or a GLP-1 receptor agonist. And this remains same with most of the other guidelines. So I'll just give at the end a preferred simplified approach to the patient with type 2 diabetes whom we see in clinical practice. So if the patient, if we see a patient with diabetes with A1C more than 6.5%, so lifestyle therapy and metformin is still the initial choice of treatment. So if the initial HbA1c is less than 7.5, a monotherapy can be considered. So the most important thing we must look at is whether the patient has atherosclerotic cardiovascular disease or high risk for ASCVD or a CKD or a heart failure. So if any of these things are there, then we must start the patient preferably on a long-acting GLP-1 agonist or an SGLT2 inhibitor such as EMPA or dapagliflozin or canagliflozin. So these can be started, these have to be started irrespective of metformin, even if HbA1c is less than 7.5. So if the initial HbA1c is more than 7.5, suppose 7.5 to 9 or 10%, then a dual therapy needs to be considered. So the second choice can be a GLP-1 or SGLT2. And if cost and if there are other concerns, then DPP-4 can be considered. And if the patient does not have any ASCVD or high risk, and if cost is a concern, then thiazolidinediones or sulfonylureas can be considered. And in 3 months, again, if the control is not achieved, we must further intensify the treatment to a triple therapy. And if the initial HbA1c is more than 9%, or if the patient has any catabolic symptoms of weight loss or polyuria or anything, then we must always consider initiating an insulin in the first instance. So I would like to end my talk here, and I would again like to thank the Department of Pharmacology of GADAG Institute of Medical Sciences for giving me this opportunity. So I'll be happy to take any questions if there are.
The session is open for question and answers. Sir, delegates have typed some questions. I'll read out, sir.
Yes.
Is there any incidence of carcinoma with SGLT2 inhibitors?
No, as of now, there is no trials or no any trials have shown any increased incidence for any kind of carcinoma with SGLT2 inhibitors. I don't think we should be concerned about the carcinoma risk as of now. Of course, these are still relatively newer agents, so we need more long-term data. But as of now, there is no increased carcinoma risk for SGLT2.
I'll take out the next question, sir. Will UTI leading to sepsis increase in case of SGLT2 inhibitors?
I didn't quite understand the question. Can you repeat? Will UTI?
UTI leading to sepsis increase in case of SGLT2 inhibitors?
Genital mycotic infections are more common with SGLT2 inhibitors, but here UTI and sepsis are still very rare complications, but in certain predisposed individuals can occur. Of course, we must always educate the patient regarding the symptoms of UTI, stress on the importance of adequate fluid intake also. And definitely, we also avoid SGLT2 inhibitors in any hospitalized patients undergoing procedures. So again, such patients, we tend to avoid SGLT2 inhibitors during the hospital stay because of slight increased risk for these complications. So of course, we have to be careful regarding complications.
One more question regarding insulin we will take in the next session. So can we take one more question, sir?
Yeah, sure.
Can we give SGLT2 inhibitors in women with risk of osteoporosis?
If especially in elderly menopause and osteoporosis, if is already on treatment for osteoporosis, then we must be little cautious regarding the use of SGLT2 inhibitors, especially canagliflozin. But again, we must also balance the cardiovascular risk for the patient. So if the patient is at moderate risk for cardiovascular disease, we can avoid SGLT2 inhibitors and consider other agents in such patients who are at very high risk for osteoporosis or who already have osteoporosis. But again, if the patient is at high cardiovascular risk or already has established atherosclerotic cardiovascular disease, if we are not able to initiate GLP-1 agonist, then we can consider SGLT2 inhibitor at lower doses, even 5 to 10 milligram of empagliflozin with adequate calcium, vitamin D supplementation and treatment for osteoporosis is relatively safe, I feel, if the patient has high cardiovascular risk. But again, as I told, both SGLT2 and GLP-1 receptor agonists have similar cardiovascular benefits. So in patients who have certain higher risk or certain relative contraindications for SGLT2, we must try to initiate the GLP-1 agonist. We can go for the weekly semaglutide or dulaglutide, or even the oral semaglutide is available now. So we have to consider that also. So,
due to time constraint, we'll wind up with the first session. Thank you, sir, for elaborating how SGLT2 inhibitors are taking the importance, and also sulfonylurea is taking a back seat. Thank you very much, sir, for joining us in a very short notice and sharing your experience with the case scenarios. Thank you so much, sir.
oh, thank you. Thank you so much for the opportunity.
Thank you, sir. Thank you so much.
Now we'll start with the inauguration function. It's indeed my great pleasure to extend the warm welcome to the dignitaries of GADAG Institute of Medical Sciences on behalf of Organizing Committee, Department of Pharmacology, in association with Rajiv Gandhi University of Health Sciences. Now I request Mr. Sarvajit and Vishwajit to invoke Lord Ganesha by singing invocation song.
महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिम् महादेवसुतं महादेवसुतं गुरुगुहनुतं महादेवसुतं गुरुगुहनुतं मारकोटिप्रकाशं शान्तं मारकोटिप्रकाशं शान्तं महाकाव्यनाटकादिप्रियम् महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकाप्रियं महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकाप्रियं पापमगमरि सरि सनि स पमगम पादनि सरि गम मरि सरि सनि पम सानि पमगमनि पमरि गमरि रि स सानि पमगमरि सरि ग महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिम्
Thank you, Sarvajit and Vishwajit. Now I request Dr. Mrutyunjay Mirje, Associate Professor, GIMS, GADAG, to give the welcome address.
Good morning, everyone. On the auspicious Thursday, it's my pleasure to welcome all the participants today for International CME 2022 on current therapeutic approaches to diabetes mellitus, a comprehensive update. I welcome all the eminent speakers and guests to share their knowledge and vast experience with the delegates. Diabetes mellitus is one of the major health diseases in the world. In India, its studies shown that by 2030, around 80 million people will suffer from diabetes mellitus. Therefore, we have tried to encapsulate in today's CME about recent advances in the management of diabetes mellitus by renowned speakers. This is the 4th international CME we are conducting from Department of Pharmacology in collaboration with Rajiv Gandhi University of Health Science, Bangalore. GIMS, GADAG Institute of Medical Science, GADAG, since its inception from 2014, our college has achieved many milestones, along with undergraduate recognition. That is, while first batch doing its internship, we have got permission to start postgraduate also. Along with undergraduate, postgraduate, our institute also started super specialty fellowship, nursing, paramedical, and allied health sciences. This is all possible because of one and only very enthusiastic, energetic, and down-to-earth person, our beloved director, Dr. P.S. Busareddy sir. Director is one of the youngest director in India. Sir is also syndicate member of RGUHS and executive member of Karnataka Nursing and Paramedical Sciences, Bangalore. I think sir is out of station. He is joining. Sir joined. I welcome you, sir.
Thank you.
GIMS has accomplished many academic achievements under the constant guidance and support of our beloved principal, Dr. Mahesh Bargundi, sir. I welcome you, sir. I request Dr. Siddhamma A to give a token of gratitude to principal, sir. Thank you. Round the clock available, tireless persons. Sitting between us is Dr. Rajshekar Magari. Sir is one of the youngest medical superintendent. Many great progress our hospital has achieved under his leadership. I welcome you, sir. I request Mr. R.T. Desai to give a token of gratitude. Thank you. In Kannada, there is a saying, Murti chikkadadaru kirti doddadu. Meaning smaller the person, bigger his achievements. One of our guests joined online. He's a gold medalist, very enthusiastic and a great academician. Since the starting of our college, he is our district surgeon. Is none other than Dr. G.S. Palle, sir. I welcome you, sir.
Thank you, sir. Thank you. Thank you.
Thank you.
Thanks.
One more person we are missing is our HOD, sir. He is due to unavoidable circumstances. He is out of station. Dr. Sunil I. Majgi, sir. Under his guidance, we are doing this CME. I welcome you, sir. I request all the dignitaries to inaugurate the function by lighting the lamp and watering the plant. Thank you, dignitaries. I request Mr. Praveen to give a token of gratitude to Dr. J.S. Palle. Thank you. Now I request our beloved director, sir, Dr. P.S. Busareddy, sir, to speak a few words.
ಕೇಳಿಸ್ತದೇನಾ ಮಾತಾಡೋದು? ಹಲೋ,
ಕೇಳಿಸ್ತಿದೆ ಸರ್.
I wish you all the best. I heartily congratulate the team of pharmacology for conducting the international CME. So wish you all the best. Thank you.
Thank you, sir.
Thank you, sir. I request our beloved principal, sir, to speak few words.
A very warm good morning to one and all. Very happy to know that our Department of Pharmacology is conducting CME on current updates in diabetes mellitus. So diabetes mellitus is one of the oldest diseases we have heard. We know it, and since then we are not, despite of that, we are not able to eliminate it. Researches are going on, so we need to update ourselves regularly to control the chronic disease diabetes mellitus. In this regard, our Department of Pharmacology is conducting an update on current trends in diabetes mellitus. For this, our Department of Microbiology staff, Dr. Rajni, Dr. Mrutyunjay, and all other staffs have really worked hard since last 1 week, and I wish them all the best. And I also welcome and thank all the national and international speakers for this CME on behalf of our director, sir, and the Department of Pharmacology. Once again, I wish the CME a grand success. Thank you.
Thank you, sir. Thank you very much. Now I request our beloved medical superintendent, Dr. Rajshekar Magari, to speak words. Few words.
On India. Good morning, all. I welcome on behalf of GADAG Institute of Medical Sciences, all the esteemed speakers and all the delegates to the CME. And I congratulate the Department of Pharmacology for conducting the CME. And they have always been conducting all the academic activities, even in the past few years. And they were also part, I think, they were established ADR pharmacovigilance unit in GIMS GADAG ADR reporting center. And also on the clinical front, they are contributing for a therapeutic and drug committee. So their contribution is continuous for all the services of GIMS, and I congratulate them and I wish them all the success for this current year. Thank you.
Thank you, sir.
Thank you very much, sir, for your kind words.
I request our district surgeon, Dr. G.S. Palle, sir, to speak few words.
I'd like to congratulate whole Department of Pharmacology for conducting this CMA, and I wish all the best for the CMA. Thank you.
Thank you, sir.
I thank all the dignitaries for joining us and wishing us the best for the international CME. Thank you so much, sir. Now we will continue with the next session, the second session of today. We'll start the session in another 5 minutes.
10:30.
By 10:30. Is Dr. Harsha sir on the talk, the next speaker on the line? We will have a 5 minutes break before starting the next session. Is Dr. Harsha sir on the call? So can you please confirm if you have joined? Is Dr. Harsha on the call? Sir, can you please confirm if you have joined, sir?
Hello, good morning. Can you please come in?
Good morning, sir. I can hear you. Thank you for joining, sir.
Yeah.
So we'll start the session in another 2 minutes, sir.
Sure.
Now let us have a second session of today's CME on novel insulins, newer opportunities to individualize therapy. Dr. Harsha Kasati, sir, am I audible, sir?
Yes. Can you hear me all right?
Yes, sir. Thank you, sir, for joining us. I am very privileged to introduce Dr. Harsha, sir. Dr. Harsha is an MD Pharmacology from MS Ramaya Medical College, Bangalore, Karnataka. Sir has done his DNB Clinical Pharmacology and also Executive MBA from the prestigious institute IIM Bangalore. Sir is UK affiliate, High Performer and Best Manager of the Year awardee for 2020. And he has delivered around 20 medical publications in leading national and international journals. He has successfully executed medical affairs projects for diabetes and cardiovascular therapeutic area. He is presently working as medical affairs manager in Novo Nordisk in the United Kingdom. We are very fortunate to have you with us, sir. Now I hand over the platform to you, sir, to begin with the session.
Can you hear me? Can you please confirm that you can hear me?
I can hear you, sir. Welcome, sir.
Okay, brilliant. I will start sharing my slides. Please tell me when you can see the slides.
Yes.
I hope you can see my slides, yeah?
Not yet, sir.
Okay, I'll give it a couple of seconds because I can see hopefully it should come up. Let me know once the slides are, you're able to see the slides.
Yes.
Can any other participant confirm that you can see the slides? Because I can see here you are sharing the screen.
Now it's coming, sir.
Thank you. Good morning, everyone. Lovely to meet you all virtually. When the opportunity to present this was given to me, I thought it's a great opportunity to actually travel to India, but it seems like it's really not. Rajini, next time when you plan to invite me, make sure it's face to face so I get an opportunity to come and meet family and friends as well. And it's great to see you all. I just want to make sure my disclaimers and disclosures are quite clear. I'm presenting here in this conference in my individual capacity as the medical expert in the area. These views do not represent the views of the company Novo Nordisk or King's College London for both of which I'm affiliated. So I'm a full-time employee at Novo Nordisk UK, and I also hold shares with the company. So hopefully, when I'm talking about Novo Nordisk products, so just be mindful of that. I'm also a visiting lecturer at the King's College London, and I have not received any honorarium for making this presentation. What a fantastic story. I think I understand many of you might actually love Bollywood movies and maybe Hollywood movies as well. In my view, the discovery of the insulin was no less than a fantastic movie, because it was a really exciting story. And if you go back in time and look about in terms of what used to happen for children living with type 1 diabetes before 1920s, it was literally a death sentence. The average life expectancy for these children was about 1 year, 1 year from the time of diagnosis. They were put on some severe carb restriction diets, and such as those Professor Jocelyn in the US tried to do that. Those things essentially increased their lifespan by about 6 months, but really didn't make a big difference to the life. And I draw your attention to the first picture to the left of your screen, where you see Dr. Banting, who was an orthopedic surgeon. He was working in the army in Canada. And what happened was, when he came back from his armed force services, he was curious to see if he can help these patients. So basically, he went to the University of Canada and met Professor MacLeod. And Professor MacLeod, had a wonderful lab, and he really wanted to. He was reluctant, but he said he's going to help Banting to do some work. So he basically gave away some research space. He gave him 10 dogs initially to do his experiments, and he picked up a coin. And what he did with the coin is, with the flip of the coin, he decided who will be the medical student who will actually help Banting in his research. And Best was lucky to be the winner of this the toss, and he ended up starting to work with Banting. So together, the two gentlemen started to work with the dogs, and when they started to inject the pancreatic extract from dogs to a pancreatectomize another dog, they could see that the dog would survive, and that kind of findings. MacLeod was more excited by what was actually happening in this research, and he said he's going to give more money. And finally, the day arrived when, there's a lot of story. I can go on and talk about this fantastic story for the rest of the hour, but I'm not going to do that. Then what happened is, the second picture in the middle of the screen, you can see this teeny little boy. His name is Leonard Thompson. He was the first patient to actually receive the insulin therapy. You will also wonder what was the role of Collip, who was already there here. Collip actually was a pharmacist who actually helped in purifying the insulin that Banting and Best produced. So his role was remarkable as well, because if we didn't get the purity of the insulin, they wouldn't really be able to inject it to Leonard Thompson. Leonard Thompson was literally on his deathbed, but when the injection was delivered, he started to recover. He went on to live another 17 years up to his mid-20s, and then later he died of pneumonia. It was not just that, a lot of many other children. You can see this lovely letter written out by a kid, which read, "Dear Dr. Banting, I wish you could come to see me. I am a boy now, and I feel fine." And these were some emotional letters being written out to the Professor Banting. And of course, the Nobel Committee recognized this, and in 1923 gave away the award to Professor MacLeod and Banting. There's a lot of debate about why only those two received, while Collip and Best did not. But more importantly, Banting and MacLeod decided to share the money with Best and Collip. So together, those four gentlemen really started off a fantastic journey in the history of insulin therapy. You also see this wonderful couple there, Professor Dr. August Crowe and Murray Crowe. Dr. August Crowe was a Nobel laureate himself, and he was on an international tour when he encountered what was going on in the University of Toronto. And he said, I live in Copenhagen. My wife is a type 1 diabetes herself. I'm interested in passing on this benefit to a number of people in Europe. And therefore, he acquired the patency to create insulin in Europe. And that's the beginning of Novo Nordisk as a pharmaceutical company, which was able to actually commercialize alongside Eli Lilly in ensuring millions of those type 1 diabetes patients actually got insulin. And finally, Hagedorn, he was the man who actually made sure that this insulin, which was discovered, was fantastic. People had to take it 3 or 4 times every day, or maybe 5 injections. He made the life much more simpler by using the technology of the neutral protamine, where Hagedorn actually combined it to make sure this insulin lasts longer, works longer. Therefore, rather than multiple injections, people could take a few injections. So a fantastic story. It's injustice to actually say that in a few minutes, but I appreciate we don't have a lot of time, so I'm going to move on. Now, why insulin is important? One must understand that we have all these treatment options available for type 2 diabetes. We're privileged actually to have all these treatments for type 2 diabetes. But look carefully what happens with those treatments, and look specifically at metformin. Many of you may well be using that as a treatment option. The average HbA1c reduction with metformin is about 1 to 2%. The average HbA1c reductions with the DPP4 inhibitors is about 0.5 to 0.9. The average with the sulfonylureas is 1 to 2%. Insulin is still the most efficacious treatment when it comes to reducing glycemia, right? And glycemia is important. We have learned that. We have learned that for both type 1 diabetes. We also learned that for type 2 diabetes. Type 1, we have the DCCT trial, which has demonstrated that quite clearly. And in type 2, UKPDS has also proven that quite clearly. Now, if you wonder, I got a patient with a HbA1c of 8%, what do I need to do? Think carefully, because every 1% reduction in HbA1c decreases deaths due to diabetes, reduces cardiovascular disease and heart attacks by 14%. It reduces stroke by 12%. It reduces the risk of the amputation of the lower extremity by 43%, which is the peripheral vascular disease. And it also reduces the risk of microvascular complications such as the thymopathy and nephropathy by 37%. So therefore, insulin is really critical in the overall discussion about management of diabetes. And we already talked about this, so I'm going to skip this slide just in the interest of the time. Let's sort of draw ourselves back to the biology, and I'm just going to talk about 3 important aspects today. I will focus on the rapid acting insulin in the first part of my talk. I will focus on the basal insulin evolution and what's really new in this area, and then finally I will focus on the premixed insulin component. Now let's start with the rapid acting insulin component here. Now, if you look at the physiological insulin secretion, so there are 2 aspects to the physiological insulin secretion. Now, the basal insulin secretion, and this happens in a pulsatile fashion all through the day, and that is the insulin that is responsible for keeping your blood glucose within the normal range all through the day, is actually driven by what is known as basal insulin secretion. And that basal insulin secretion contributes to 50% of the insulin secretion in any individual. Then you see those 3 arrows, and those 3 arrows actually represent the insulin secretion, which is prandial insulin secretion. And that prandial secretion of the insulin happens every time an individual takes the meal, right? Now what we are trying to achieve with the treatment of various insulin therapy is we are trying to achieve a physiological, near normal physiological insulin secretion. So we have this whole group of basal insulins that I showed you in the previous table, which will focus on providing a basal coverage of the insulin all through the day. Then we have prandial insulin. Sorry, there's a bit of noise in the background. If you can please mute yourself. Okay, so we've got the basal insulins, which look after the basal requirement of the insulin. We got the prandial insulins, which look after the requirement of the insulin after the meals. And that's what we're trying to achieve with the insulin therapy, to be able to deliver both the basal insulin as well as prandial insulin. Of course, you must also remember that in type 1 diabetes, there is no secretion of the insulin. So you're trying to actually cover both the basal as well as the prandial, whereas in type 2 diabetes, it's not necessarily the case. At the diagnosis, 50% of the insulin secretion is reduced, but there is some insulin secretion endogenously. Again, can I please ask you guys to mute? I can see some background noise, please. Then let's talk a little bit about what is an ideal insulin. Firstly, let me make it very clear to you. There is nothing ideally available as the most ideal insulin, right? So we have insulins which are quite close to physiology, but there is nothing called as an ideal insulin. Now, when we say an insulin is an ideal insulin, we're talking about an insulin which provides mealtime flexibility. There would be type 1 diabetes small children who do not want to take insulin before meal because you don't really know how much they eat. Or maybe they're elderly people who wouldn't want to inject a large dose of injection before the meal. So you really need an insulin which provides mealtime flexibility. You also don't want a situation where you've taken the insulin and then you cannot have the meal because you've got something urgent. So you would want an insulin that you can take just before the meal, or you could also take after the meal. So the whole concept of an ideal mealtime insulin is one which has got a lot more flexibility. Better glycemic control. I mean, in terms of HbA1c alone, I don't think there is a lot of difference between different types of insulins because they all produce an unlimited level of glycemic control. So really, that is not the part, but it is the important component. Is a good basal insulin produces good fasting plasma glucose control. A good prandial insulin produces good postprandial glucose control. So you really need an insulin that has got the ability to do that. The third bit is about variability with an insulin. So, assume you're standing in a bus station and a bus arrives at 7 o'clock in the morning. You're waiting for a bus in the morning at 7 o'clock to go to your work. Let's say a bus arrives at 7 o'clock on one day. This bus arrives at 6:30 on another day. It comes at 6:45 another day. Let's say 7:15 another day. That's exactly what happens with the insulin therapy. It means that you cannot predict how the insulin will work, on every single day basis. So it works very well on a day. There's a bigger peak versus another day. So what you want with an ideal insulin is the one which has got the minimal variability. Like, for example, in the situation of the bus that I explained, you want that bus to arrive exactly at the same time so you can travel and plan around the rest of your life, comfortably. So that is also an important aspect of an ideal insulin. Hypoglycemia and weight gain are critical aspects of the insulin therapy because they're also some of the areas of concerns one would actually anticipate when you're using insulin therapy. So an insulin is ideal if it produces less hypoglycemia. There is no insulin which produces no hypoglycemia, at least at this stage. Hopefully there would be one in our lifetime in the future. And then there is no insulin which does not produce any weight gain, but we're looking at an insulin which produces some level of minimal weight gain. And of course, more recently, I think we also understand that patients do not want to inject these big needles. So therefore, we need easy available pens which are painless and simpler from a patient perspective to be able to inject these insulin. So that is, a picture perfect situation that I'm trying to explain. And one must remember that actually there is none that you can call as an ideal insulin. There are insulins that are getting closer to the physiology, that are insulins that are getting more closer to the ideal scenario, but there is nothing which is absolutely there in terms of what I showed you in the previous slide. We discussed about some of the key challenges with why, despite all these fantastic benefits that I spoke about in terms of the insulin therapy, people don't still prescribe insulin therapy. A lot of people, especially patients, having worked in India, I understand there's a huge fear of injection. They wouldn't want to inject an injection every single day. People are worried about, am I going to wake up in the morning if I take insulin therapy? Because, there are instances of death in bed, especially more in type 1, not necessarily in type 2. Generally, there is lack of awareness, about the benefits of the insulin therapy. Most patients have a tendency to believe that, once I'm prescribed an insulin therapy, it probably is the end of my life, or, this is going to produce kidney disease, etc. All of that notions that they usually gain from their close family, etc., doesn't really help in that conversation for a healthcare professional. Insulin is a anabolic hormone. We all know that. Insulin produces weight gain. Insulin can produce anywhere between 3 to 6 kilograms of weight gain over many years of treatment. That, of course, is not helpful for type 2 diabetes as well, because, the more the weight gain, higher is the insulin resistance. That's not really helpful. And some people, also have this challenge about, when do I take the insulin? Should I take it at the same time every single day? All of these overall sort of pose the challenge to the insulin therapy. Now let's try and build a little bit of focus and then try and focus on rapid acting insulin. So in the rapid acting insulin area, we've got human rapid acting insulin, which is the human insulin, which we know as Actrapate for many years, and most of you already use that. Then we have the next group of insulins, which are called as insulin analogs. So basically what has been done is you make some structural modifications in the B chain or the A chain of the insulin, and then you create some analogs. We have got the insulin aspart, which is available as NovoRapid. We have the insulin Lispro from Eli Lilly, which is available as Apidrop. And then you also have insulin glulisine, which is from Sanofi. So you got Humalog, Aspart, and Apidrop, and they are biologically known as Aspart, Lispro, and glulisine. There is also more recent developments in this area, especially in the last 3 to 4 years. There are insulins which are much faster than the analogs. So I put that together as a newer insulin analog. There are two important ones here in this category. There's a faster acting insulin aspart, and there's also an ultra rapid acting insulin Lispro. Okay, now I will show you a brief picture, and that kind of demonstrate how actually these things work. Let's look at this picture. I hope you'll be able to see it. That's human insulin for you. And the second one is insulin aspart, and the third one is faster aspart. Now, what you can see is the human insulin, the monomers of the insulin are taking more time to break up and reach the systemic circulation. With the insulin aspart, the monomers of the insulin are able to break much more quicker, and therefore, it's much easier in terms of systemic circulation absorption. And finally, if you look at the faster aspart, you can see it's much more faster than the insulin aspart, and being able to deliver that much more quickly. Therefore, there are subtle differences in the way the human insulin works to that of the insulin analog. So the human insulin takes a lot more time to be able to break down into its insulin monomers and absorb into the insulin circulation. So what does it mean in terms of real life? It means that a regular human insulin will take a lot more time to be able to reach the onset of action. It takes about 30 minutes, as you can see there in the screen. It takes more time to be able to peak. Therefore, you might imagine that a regular insulin may not produce the same level of postprandial glucose control. You could also see it acts for a longer duration of time. So there is also the risk of hypoglycemia with the human insulin. Now, in terms of the comparison with the insulin aspart or the NovaRapid, I'm sure many of you may well be aware of that. It takes only 10 to 20 minutes to start acting. It reaches the peak concentration within an hour and completes its action quicker as well. So what it means in terms of reality to what the benefits of the patients are, that they can actually take it just before the meal. They don't have to wait. Sometimes they can also inject it after the meal. There is a much better postprandial glucose control with insulin aspart or glulisine or epidrub. And this is just one example I'm trying to show you. And then there is less risk of hypoglycemia as well. Now let's look at what happens in terms of the differences between the formulations of these insulins. Now, I already told you about the whole idea of evolution within the prandial insulin space is basically about making sure the hexamers of the insulin in the subcutaneous tissue are able to break down into monomers much quicker and faster. So in terms of the insulin aspart, there's just small changes in the structure. And when you make those small changes in the structure, what happens is the interaction between the two monomers within the hexameric structure becomes lesser, because proline, which is being replaced, is actually one of the components which is keeping this interaction between the multiple hexamers. And when it is removed, so that interaction between the monomers becomes lesser, so the insulin breaks down faster. Now, if you look at the faster aspart, which is the next level. Just a quick request again, can you please keep yourself muted to avoid any confusion. Now, when you talk about the faster aspart, we have added niacinamide. Niacinamide acts to help the absorption of the insulin aspart. It also helps in the stability of the insulin aspart, making the insulin aspart act even quicker. So if you look in the bottom of this picture, you can see that the faster aspart actually starts to produce its action even before insulin aspart. It reaches a peak concentration even before insulin aspart. It also therefore results in a much better postprandial glucose control, 1 hour postprandial glucose control and 2 hour postprandial glucose control. That was demonstrated in the clinical studies, and that is also shown in the graph here that I can actually highlight. In terms of the outcomes for the postprandial glucose. This is the this is the 60 minutes postprandial glucose. This is the 2 hour postprandial glucose. The dark blue curve represents the curve for glucose values for people treated with faster acting insulin aspart. The light gray line represents those who are treated with the normal insulin aspart, which is NovaRapid, and you can see the difference. And equally, if you look at the pharmacokinetic and pharmacodynamic graphs, you can look here. This is the blue line again representing faster aspart. The curve is shifted towards the left. You can see it acts faster. It has a much higher peak and also comes down quicker. So that is really how these things sort of work. This is equally true for another newer acting, ultra fast acting Lispro, which was recently approved, I understand, in the last couple of years. I'm not entirely sure if it's available in India, and it again adapts a similar technology where they include a vasodilator, which makes the absorption faster. You can again see what it means if you're a clinician and treating patients is the reduction. Can I please ask Lavanya to please mute herself? And then you can see clearly the 1 hour postprandial glucose, the 2 hour postprandial glucose is much better as compared to that of a regular insulin lispro. So really, that's what we are trying to achieve. So this is the normal pancreatic physiology. It reaches the peak very quickly. That's what we want to achieve with the prandial insulin. This is the regular human insulin. This is the rapid acting insulin analog. And what we're trying to achieve is try to come more closer to the physiology with these newer insulin analogs. We did that pretty well with the first three I'm talking about, which is the insulin lispro, insulin glulisine, and insulin aspart. But we can do it much better with the fast aspart and ultra rapid rispro. So this is a summary. I can understand this has got a lot of content and data, but what I wanted you to be aware is there are the three conventional analog insulins, which is the lispro from Eli Lilly, the glulisine from Sanofi, and aspart from Novo Nordisk. There are two newer generation of the fast-acting insulin, which is the faster aspart, and then which is called as PHARMACOLOGY, and there is the insulin lispro, faster acting or the ultra rapid acting lispro. You will also note there is an Afrezza, which is the inhalation insulin by Mankind. Mankind, not the Indian Mankind. There is a company. There is another Mankind company in the US which has actually produced this. This is only recommended for people who do not have any smoking or any COPD, etc. This has not become very popular because the efficacy is modest. There's also some major warnings in terms of when it needs to be taken, as well as the safety in terms of the lung. It is available, but isn't really that popular. The faster aspart is the more recent one that has arrived in the last 2 or 3 years. I hope it's available in India as well. Insulin aspart, of course, it's been there for the last 20 years. A lot of biosimilars are now coming through for the insulin aspart, as well as for the insulin lispro. Glulisine is the one which is produced by Sanofi, which probably is the less popular out of the three. But interestingly, there are some concerns with the use of the glulisine, I believe, in the pump. I don't have further details, but this is just a broad summary of how the overall bolus insulins look like. Okay, now what does it mean in terms of the future? In terms of the future, we are getting very close to the physiology with these insulins. So really not much room for innovation. If you look at the development in the next few years to come, there's nothing in the phase 3. There are a few developments in the phase 2. Some of them are actually combination insulins. And finally, you can see a lot of biosimilars coming into the market. So biosimilar insulin aspart, biosimilar insulin lispro are also sort of getting into the development of the insulin. So that is in a nutshell an overview of what's going on in the bolus insulin area. Now switching the gears, and I'm now talking about basal insulin. Now in the basal insulins, we got the innovation from Hagedron, which is the neutral protamine Hagedron insulin, the NPH insulin that I think most of you are familiar. And then we have the glargine, which is available, I believe, in India as Lantus. It's available in two different formulations, as U100, and a more recent one called as Tujoya, which is the U300. Then there is the insulin Detimir, which is available in the brand name as Levimir in India as well. Those are sort of the key important basal insulins. And we'll try and understand how these insulins are actually different from one another. So we started off with the NPH insulin in the 40s. Then we're moving into the insulin Detimir. And then in the 90s came the insulin Glargine. And then now more recently, we've got the Glargine U300 and insulin Degludec. I want you to just focus on what is the difference to the patients. In terms of the difference really is the half-life of these insulins. So the insulins with the increasing protraction which means it's increasing ability to act for a longer duration of time, you can see the half-life is increasing. With the NPH, it was about 5 to 10 hours. With the glargine, 7 to 13 hours. And then with the insulin degludec, it's about 25 hours. So that is exactly what is happening in terms of the innovation in the basal insulin space. So what you basically want with the basal insulin is you want a basal insulin which actually works for a longer period of time. It works in a stable manner with less variability and produces less hypoglycemia. So that's really what you're looking from a basal insulin perspective. To demonstrate to you in simple terms, I will show you a representation of how insulin degludec works for longer duration of time, right? This is essentially the opposite of what we were trying to achieve with the bolus insulin. With the basal insulins, what you're trying to do is you want the insulin to act for a long period of time. And this can happen if this insulin, which is injected into the subcutaneous tissue, does not break down into monomers, actually stays as hexamers. This also happens if this insulin can bind into the albumin once absorbed from the subcutaneous tissue, so it can stay with the albumin, therefore not available for breaking down from the liver or from the kidney, or for this insulin to be being able to escape the breakdown mechanisms in the kidney and in the liver. Now, take a look at this one. There's no audio, but you can see here the monomers of the insulin are actually coming together, and they form what is known as long chains of hexamers. And these long chains of hexamers is formed in the subcutaneous tissue, and you can see in the next picture, the individual hexamers are broken down to release the insulin over time. So basically, this is exactly what happens with the basal insulin. Over a period of time, the insulin is broken down into monomers, and then as a result of that, you can see the insulin acts for a long duration of time. Can I just check with the organizers if there is any background noise or if everything is okay in terms of the audio?
No, sir, it's clear.
Thank you. Okay, now let's just demonstrate to you what's the difference in terms of how different insulins act for a long duration of time. The NPH insulin was very simple. So the NPH insulin, once injected into the subcutaneous space, basically it forms crystals of insulin, and as a result of these crystals, the insulin gets absorbed slowly from the subcutaneous space, but it had a lot of variability. I already showed you the mechanism for insulin degludec. It forms long chains of hexamers. In terms of insulin glargine, which is Lantus, it's acidic in nature as an insulin, and when it is injected into the subcutaneous tissue, insulin glargine actually forms what is called as precipitates or microprecipitates, and then monomers of the insulin are released from the precipitate. And the reason why it forms precipitates is, of course, it's acidic in nature. When you put it in an environment which is basic, it forms precipitates. And insulin glargine U300 is the newer version of the insulin glargine U100. This forms even more concentrated precipitates from which the insulin takes even more time to be able to break down. As a result, has got a longer half-life. Again, as you can see here, what we're trying to achieve by these different types of these insulins is to increase the half-life of the insulin. So with the insulin degludec, it's about 25 hours. With the insulin glargine, it's about 12 hours. Insulin glargine U300, 19 hours. And you can also see just small structural differences between 100 and 300. We talked about the profile. Just to sort of show you again, the onset of action of the NPH insulin is 1.5 hours, reaches peak in 4 to 12 hours, acts for about 24 hours, with a lot of variability. And in the next slide, I can clearly demonstrate to you, if somebody is being injected with NPH insulin, look what happens. When somebody is being injected with insulin glargine, look what happens. You can see clearly we made some difference. With the NPH, the variability is much higher. With insulin glargine, you can see the variability has come down. It's actually not completely disappeared, but the variability is much lesser. What those variabilities also mean is when these peaks happen, that is when patients end up developing hypoglycemia. And when these troughs happen, that is when patients end up developing hyperglycemia. So therefore, the number of troughs and peaks is much lesser with glargine, therefore produces less risk of hypoglycemia. It's even lesser with insulin degludec, because degludec actually is much more flatter as compared to that of insulin glargine. This is insulin detimab, again an evolution over insulin glargine, and then we had the next development in terms of insulin degludec. Right. Now let's look at what it means in terms of the clinical outcomes for the patients. All of them produce the similar A1C control. There's actually not much difference in the HbA1c, but really the key differences is in the risk of hypoglycemia. A basal insulin, which is much more flatter, which is much more longer acting, produces lesser risk of hypoglycemia. It produces lesser risk of nocturnal hypoglycemia as well as severe hypoglycemia, and that is one thing to be mindful of when you're using these insulins. This is a broad overview and summary of what the differences are. Insulin degludec has the longest duration of action in terms of all these insulins. You can have the flexibility of administering it. You don't have to give it at the same time every day. You can give it at different times, as long as the time between the two injections is minimum of 8 hours. It offers you, the risk of lower hypoglycemia as compared to insulin glargine. Obviously, of course, it's more expensive than insulin glargine, so you will have to keep in mind the ability of the patient to be able to afford those insulins when you use that. Glargine U300 actually is also much better than insulin glargine U100. It produces less hypo versus U100. There is not much differences between degludec and glargine U300. There is some controversies with the individual studies done comparing those two, but overall, you can see that they are much more flatter. They offer you the opportunity for once daily dosing, and then they also produce a good fasting plasma glucose control. With detimab, which is available as Levemir, is much more relevant in type 1 diabetes because it's much more stable. It's quite popular here in the UK. A lot of patients on type 1 usually are on insulin detimab. And then, basically you can also use that in pregnancy because there's good data to demonstrate that it is safe in pregnancy. Insulin detimab also has the least weight gain in terms of the existing basal insulin. Right. What's happening in terms of the future in terms of the basal insulin? So we are moving away from once daily administration to a once weekly administration. So once weekly acting basal insulin analogs are just around the corner. They're going to be approved anytime soon and may be available in many of the markets. The two companies in the forefront of this invention are Novo Nordisk, who are actually working on a analog, which is a once weekly acting insulin, with a half-life of 7 days. There is also Eli Lilly's development, which is basically a combination of immunoglobulin Fc with the insulin, which helps this insulin to act for a longer duration of time. I won't go to the structural details, but I just want to show you that the data was just recently published, which is the onwards data for the insulin that Novo Nordisk is developing, which is called as icodec, which demonstrated that the once weekly administration definitely is helpful in producing good glycemic control without increasing the risk of hypoglycemia. So hopefully, probably more good news for patients. They don't have to inject every day, but maybe they could inject once in a week. And if you look at the developments in this area, there is not a lot of new things coming through in the next few years. But I think hopefully there are a few more things in the preclinical development. There's also discussion about glucose-sensitive insulin. Hopefully those may become available in a few more years' time. But again, biosimilars development is continuously progressing. Once the patency expires for these long-acting insulins, glargine now already available as multiple biosimilars, likely to happen with degludec and levimir as well with the time. Now, the final bit is the premixed insulin. I understand that we do not have a lot of time. I would like to give at least 15 minutes of time for question and answers. So what I'm going to try and do is skip a few slides and focus on the key differences between the different premixed insulins. Premixed insulins are critical in the management of diabetes, especially in India, because they provide the simplicity of the administration. You get both the basal insulin coverage and the prandial insulin coverage in the same insulin. And it all started off with the human mixed-ard, where the human insulin, short-acting insulin, was combined with the NPH insulin. So you could give that as just 2 injections in a day. And then over a period of time, Novorapid was also protaminated to produce what was known as the NoMix30, or it's called as the premix analog insulin, and that is also available for many years in India. And the good news about that is it is actually much more predictable and longer acting than the human mixed-ard. And more recently, we also just seen an evolution in terms of you don't have to protaminate an insulin. You can actually mix up 2 good insulins. A long-acting basal insulin, degludec, has now been combined with a short-acting insulin aspart to produce what is known as IDAGAS. It's available in India, I believe, as RIZODEX. What happens with these newer insulin analogs or premix insulin analogs is they reduce the risk of hypoglycemia. If you compare the human premix, which is human mixed-ard, versus the NoMix30 or the biphasic insulin aspart 30, you see a lower risk of hypoglycemia. And this was a very famous meta-analysis published by Davidson, which produced about 50% lower risk of nocturnal hypoglycemia with the analog premix insulin as compared to human premix mixed-ard insulin. This is what is the newer development in this area. You can see insulin degludec that we already discussed about forms this beautiful long hexameric chains. We also discussed about insulin aspart, which is the faster acting insulin that we know of. Now the two have been combined in the ratio of 30 and 70 to produce a single injection. So you could argue whether it's actually a premixed insulin or you can call it as a co-formulation. I'll leave that to your judgment. Basically, what it does is it produces a significant innovation in terms of further reducing the risk of hypoglycemia with the premixed insulin. This is one of the pivotal studies which was published a few years ago, which compared the outcomes with the twice daily injection of a premix analog insulin, which is NoMix30, in comparison with RIZODEX or IDAGAS, which is the combination of degludec and aspart in a single injection. You can see the reduction in the hypoglycemia. There was a 75% reduction in the nocturnal hypoglycemia and also significant reduction in the hypoglycemia of the confirmed hypoglycemia. Mind you, 75 and 34 are 54 are relative risk. You should look at more absolute numbers which are mentioned in the graph. But of course, nonetheless, there is a reduction in the risk of hypoglycemia. This is a summary of the available premixed insulins in India. I have left out mixed-ard, although it's quite popular, but just in terms of your knowledge, you are aware of it. So I've just left it out for the convenience. And this is just to give you a pictorial representation of what we are trying to achieve with the various premixed insulins, is to try and achieve a quicker rapid peak, that is the prandial coverage, and you need a more longer basal coverage and that you can see with the newer co-formulations, you're able to achieve that much more physiological approach with the insulin. Okay. Finally, the initiation of the insulin can be another topic. We can speak for an hour. Just so you know, you can initiate an insulin therapy with just a single injection of the basal. You can start with 10 units or 0.3 to 0.4 units at bedtime, and then titrate them based on fasting plasma glucose. You could also start on a premix insulin. In India, there's a high carb meals where people don't necessarily may do well with basal insulin, so you could also start them on a single injection of a premix insulin. And over time, you can move the one injection of premix insulin to 2 injections of premix insulin. You could also, start patients on a basal bolus regimen. This is less likely in type 2 diabetes, but there are individuals who would prefer to start patients on basal bolus. And that kind of narrates the whole idea of the individualization of the insulin treatment. Nothing is right or wrong with the treatment of the insulin therapy. You could move from a basal insulin to a basal plus 1 aspart, which is basal plus. You could also move to a basal bolus, or you can further increase the bolus insulin. And I'm going to summarize by saying development of the insulin therapy is a fantastic journey. It's not really a destination. Destination is quite far. Destination is physiology. It's not easy to achieve that, but I think I can tell you that we are progressing in the right direction. But if I'm being really honest with you, in terms of the summary, you can see there is a lot of development in the area of diabetes. 1 hour probably is not sufficient for me to cover a lot of these things that are happening within the insulin space, but I try to do my in terms of justice to the topic by covering the key developments. So insulin remains the cornerstone of management of diabetes, both in type 1 and type 2. 100 years into the discovery of the insulin, the quest for the more physiological insulin continues to happen, although the newer ones offer flexibility, lower risk of hypoglycemia, and lower weight gain. It's not still the most ideal insulin. The innovations in the insulin space are becoming more incremental. Are there really big innovations happening? As you can see, a lot of biosimilars coming through. Maybe there are not too many newer insulins coming through, but hopefully we might see a lot of change in this area. A lot of innovation now is in the space of GLP-1 rather than in the insulin space, but fingers crossed what might come through in the future. So I'm going to stop there and stop sharing the screen, and hopefully you should be able to see the bigger screen and have the opportunity to ask questions. Thank you for your attention. Thank you, organizers, for giving me the opportunity to be able to come here and speak to you all virtually.
Thank you, sir. The session is now open for question and answers. Anybody, they can unmute yourself and ask the question.
Madam, I have a question. Can I ask?
Sure, sir.
Yeah, very nice presentation and useful too. You mentioned, sir, about basal insulin once a week injection, which looks like a very fantastic development. But will it create some problems regarding hypoglycemia, hyperglycemia management with this kind of long-acting insulin? Thank you.
Very good question. I can understand. If I was a clinician, I would be concerned as well, because you're looking at injecting 1 week of insulin into the subcutaneous tissue right away, and you would of course be worried about hypoglycemia. The good news is the top line results of the once weekly injection compared to insulin degludec were just presented at the ADA conference this last week in the US, and there was no difference in the outcome of the hypoglycemia between insulin degludec versus the insulin once weekly insulin. So as I understand, you have concerns, but the data does not demonstrate that there is any risk of hypoglycemia.
Yes, sir. Thank you. Thank you very much.
Any more questions from the delegates, please? Delegates, if you have any questions. So we have one question from our side, sir.
Yeah.
There's a one question, sir. Can I ask one question?
Yeah, please proceed, sir.
So as we all know that insulin, we are injected half an hour before the meal and all those things. What happens in a post-prandial hyperglycemia? Sir, hyperglycemia, it will be controlled or it will only controlling the basal levels?
Good question.
Because the insulin level, what we are giving is maintaining the same level once in a week. But how does it control the postprandial hyperglycemia and basal levels?
Good question. So the question, the once weekly insulin we're talking about is only a basal insulin. It helps you only control fasting plasma glucose. It has no effect on the prandial insulin coverage. So if you're looking at a type 1 diabetes patient, obviously you want to combine that with short-acting insulin. And if you're looking at a type 2 diabetes patient, you might have to use additional prandial insulin to be able to control postprandial glucose. So the once weekly is not to control or not to provide prandial coverage. It's predominantly for basal insulin coverage and for the control of the fasting plasma glucose.
Thank you, sir.
Good afternoon, sir. Good morning, sir. Sir, what is the future for any oral preparation of insulin? Is there any work going on? You could just briefly.
Two companies are working on this. Novo Nordisk has been working on the oral insulin for a long period of time. There is also another company called Oramed, which is, I think, an Israeli company who are also working on this space. Unfortunately, the success has not been great. And a lot of these developments have been paused because the amount of insulin that you need to actually give as a pill is a lot of insulin because the bioavailability of the insulin is very low. Dr. Shabir, can you mute yourself, please? So I was talking about why this is not possible, or it's become difficult to actually produce these oral insulins, is because the amount of insulin you need to provide orally is very high versus subcut because of the low bioavailability, and therefore it's not going to be making commercial sense for patients. Assume they need to pay 10 times the cost of the the injectable insulin. Actually, they may not be willing to do that. So pharmaceutical companies are actually struggling if this can actually become a reality, simply because it's not commercially viable. The second aspect, of course, is now the GLP-1s have been formulated orally. I think in India, we now have semaglutide, which is a GLP-1 analog, available as an oral formulation. So proteins can be formulated orally, can be made available. GLP-1 is already there, but the insulin space, as I mentioned, it's not commercially viable. So pharmaceutical companies may not really want to further innovate in this space.
Any more questions from the delegate side?
What about combining metformin with injectable insulin therapy? Is there any are there patients who are being given metformin along with insulin, considering the mechanism of action of metformin, especially in type 2 diabetics?
Thanks, Dr. Sheetal. I think every single study with any insulin, basal insulin, always is on top of metformin. And the reason for that is metformin is glucose sensitive. It increases the insulin sensitivity and helps in the action of the insulin therapy. So every single study that I showed you is on top of the metformin therapy. 100% yes. All of these patients should be on a fully optimal dose of metformin of 1 to 2 grams when they're on insulin therapy.
Thank you.
Any other questions
from the data?
I can see there is a question in the chat. Nowadays, there's many advertisements coming on the reversibility of diabetes. Any role of the fast-acting insulin? Interesting question. I will answer that in two parts. Now, the reversibility of the diabetes, actually, those publications have all come from the UK. Professor Mike Lean, I know him really well. He's a good friend of mine. I have my own patients who managed to actually follow this very low calorie diet. The basic concept is there is the presence of these, the visceral fat in the pancreas. And when you lose weight of about 10 to 15%, then what happens is that the fat is removed from the pancreas and the insulin secretion restarts, and there is a complete remission of type 2 diabetes. So there's some really good data from the UK that's published in the Lancet in the last few years, which has demonstrated that. This is very low calorie diet. We're talking about 800 calorie diet, over a period of 6 months to be able to do that. I'm not entirely sure how patients are able to actually stick to this diet, but that is a different ball game altogether. In fact, Mike also mentioned to me that the amount of weight loss that is required to actually do that in Indian population probably is even lesser, maybe to the tune of 78% weight loss. There is no role for the short-acting insulin in the remission of type 2 diabetes. There is a role for short-term intensive treatment early in the type 2 diabetes, and therefore you could stop basically insulin therapy at the later date, because then the lifestyle measures actually kick in, right? So that's the answer. And there is another question on fast-acting insulins reduce complications like neuropathy and nephropathy. Fast-acting, there is no specific role just of fast-acting. It is the role of any insulin which reduces postprandial glucose. So therefore, because the fast-acting insulins are more relevant for postprandial glucose control, yes, there is data to show complications like neuropathy and nephropathy are reduced overall with insulin therapy as well as with short-acting. Is there any correlation between dairy products and sugar levels? I don't really know the details, so I'm not going to answer that question. And then there is one question in type 2 diabetes, but there is no details on the question. But yeah, no other question in the chat. Thank you.
I hope there are no other questions. So I'm Dr. Rajini. I thank Dr. Harsha, who also happens to be my very dear friend. This is my privilege that you have agreed for the CME and enlightened us about all the forms of insulin and basically how it can be given, and even the delegates were very active. So I thank you for it. Hope to see you soon. Thank you.
Thanks, Raj. Thank you for making me wake up at 5 o'clock in the morning. But hopefully, maybe I'll see you face to face next time around.
Yeah, sure.
Lovely to hear from you. Thanks a lot. Thank you for the invitation as well.
Thank you.
Now let us move to the next session. Please give me a minute. May I know Dr. Arbinder Singhal sir has joined the meeting? Sir, can you hear me?
Hi, I have joined the meeting.
Hi, sir. Good morning, sir. Thank you for joining, sir. It's my privilege and an honor to have you, sir. Now let us move on to the third session, that is on digital therapeutic approaches of diabetes mellitus management by Dr. Arbinder Singhal, sir. I am privileged to introduce Dr. Arbinder, sir. Sir is Gold medalist in pediatric surgery from renowned All India Institute of Medical Science, New Delhi. Sir is the invited speaker at Indian, American, Australian, European, and Asian conferences. He has more than 100 keynote talks to his credit and more than 50 publications and book chapters to his credit. Sir has set up 2 successful hospitals, a telemedicine business, and an NGO in health and education. Sir is presently working as CEO and co-founder Fitafly. It is Digital Health and Therapeutics, Mumbai. Fitafly is a health tech startup, works in the area of digital therapeutics, runs wellness programs in diabetes and obesity. We are very honored and fortunate to have you with us, sir. Now I hand over the platform to you. Begin with the session, sir.
Thank you so much. It's indeed pleasure to be here and really honored. I've never spoken at such kind of pharmacology conference before. Mostly I get invited to speak in digital health or pediatric urology conferences. So indeed, thank you very much and thanks for the team to reaching out. So what I would like to share today, since there are a lot of students also attending, is how do you make the digital therapeutics? And I will take you through the journey which we undertook in building this solution. Just as a disclaimer, I was the first patient on this platform and I completely reversed my pre-diabetes and I've stayed very healthy. So I know that it works. You know, when they say that everybody has a guinea pig in a clinical trial, so similar situation was mine. I was the guinea pig in this particular trial when we started developing the program. Is my screen visible?
Yes, sir, the screen is visible.
Just 1 second. Let me just put on slideshow. Great. So the first thing which I wanted to talk about today is that it is important to understand what digital therapeutics is. It is not the same as digital health. If we go to the overall landscape of digital health, in the last 20 years, what we have been doing is something called digital health, where we are using technology for better access to healthcare or better information around healthcare. But when we start using the software and technology for delivering outcomes, then it is called digital therapeutics. So it's a subclass of digital health. And here we use high quality software for interventions, and this leads to prevention, management, or even reversal of certain conditions. Worldwide, there are a lot of companies which have worked in various fields such as neurosciences, GI, cardiovascular, oncology, addiction, genitourinary, and diabetes. Now, within the diabetes space, if you look at the typical journey of a patient who has diabetes, they get diagnosed on a blood test. They go to a doctor. Doctor does the further diagnosis, then writes a pharmacological therapy, gives the basic lifestyle advice, and asks the patient to come back on a 3-monthly or a yearly basis. But what the patients actually need on a day-to-day basis for diabetes is much beyond that. Typically, doctors in India are time constrained. They are not able to spend more than 5-10 minutes for every consultation. People with diabetes need to make decisions about everything in their life, what to eat. They need to understand exercise is very important for decreasing insulin resistance. And a lot of data shows that if you don't sleep well, even for one night, your fasting blood sugars are up by 5 to 10% within one night. Similarly, stress has so much of impact on diabetes. Then, though the doctor has written medications, a lot of time people are not taking the medication regularly. They're taking 5 days a week, or they're not adjusting the doses properly. They may not be even aware of what diabetes means for their overall health and well-being, what kind of expenses, what kind of complications they can get into. For doing all this, you also require a lot of motivation and support. So if you look at the current diabetes management, for 99% of the patients, all these things are not offered by the current healthcare system. What is offered is a consultation, blood test, and a medicine, and a very basic advice around lifestyle management. So if you look at the Western world, there are companies in US like Livongo, Omada, which are now valued at more than $1 billion, and they have worked heavily in the space of diabetes management. And a few clarification. Sometimes people come to me with very strange kind of questions. They ask me, "Oh, Healthify Me is a digital therapeutic," or MyFitnessPal is a digital therapeutic, or even a BP tracking app is a digital therapeutic. No, it is not. A tracking app like a Healthify.me or a PP app cannot be called a digital therapeutic. Then people come and tell me that 1mg or a mFine or a HealthPlix is a digital therapeutic because it is offering a doctor consultation. No, that is not digital therapeutic. Then today there's a lot of buzzword around diabetes reversal, and people say diabetes reversal is digital therapeutic. No, it is not. To be calling yourself digital therapeutic, you have to develop the therapy. So typically this is how we went about it. We went assessing the market need and the business potential. Then we design interventions. There are inclusion and exclusion criteria. There is a hypothesis, there are expert approvals. Then you start a pilot with very basic technology. You assess the adaptation of this. You assess the usability and outcomes, preliminary indications, and then you start automating and productizing it. Finally, you keep on upgrading it. This is the stage where we are. As Bitterfly, we have developed this pilot. We have developed the therapy. We have proven that it works. We are automating a lot of experiences, and we'll keep on continuously upgrading it. And if you look at this, this will take anyone who wants to develop digital therapeutic minimum of 2 to 4 years. Just building an app and launching it on Play Store is not digital therapeutic. You should have done all these things. You should have proven that it works. There should be a therapy design. There should be a program design. There should be automation, productization to call yourself a digital therapeutic solution. Unfortunately, in India, there is no FDA approval which is required for calling yourself digital therapeutic. But in Western world, you require a proper FDA approval to call yourself a digital therapeutic company. So I will begin with my story because stories are what we listen to and what we are most fond of. So I was the guinea pig on this story, as I told you. So for the first 3 years of Bitterfly, which was between 2016 to 2019, we developed India's largest nutrition database. And we realized that nutrition is very closely linked to most of the clinical conditions which we see, whether it's obesity management, PCOS management, high blood pressure management, eye diseases, GI diseases, all of them have nutrition as the underlying basis. And if we can understand nutrition and give a proper healthy nutrition chart for every disease, then it can solve a lot of health issues. So we ended up creating India's largest nutrition database. And this is very different from Healthify.me or MyFitnessPal that has micronutrient database. It is linked to this. Is it linked with a lot of 18 plus diseases, and almost 10,000 dietitians use our database and software, including companies like Nestle, Abbott, Danone, Eris, Sun Pharma, USV. All these companies use our nutrition databases and calculators. Now in till 2019, this was the business model. In 2019, I fell sick and I had a couple of episodes of hypoglycemia, taken to the hospital. And then one of my friends told that, why don't you put a continuous glucose monitoring device to understand what is happening to your health. I hope all of you are aware of continuous glucose monitoring devices. So this is a small wearable device like a patch, which you can see on my left arm here, which takes an automated blood sugar reading every 15 minutes. It has an accuracy range of almost 85 to 88%. But what it does, it shows you the trends of blood sugars. And this is the kind of graph which you get once you put this device. This is my first 7 days of graph. It is divided into 4 quadrants of morning 12 a.m. to 6 a.m., 6 to 12, 12 to 18, and 18 to midnight. And here you can see my blood sugars are mostly in normal range, but early in the morning they have a rise, then late in the afternoon and early in the evening. So these rises is what I was interested in. This gray band is the zone of euglycemia, where even before eating or after eating, it should remain quite stable. And you can see this is the values like time in range, time below range, time above range is what you get as a database. Now this device has been there for a few years, but this is the kind of report which doctors are used to seeing, and they change the medication according to that. For example, if you find that there is a rise in blood sugar post a certain meal, doctors will write alpha glucosidase inhibitor to blunt that rise. Or if the person is on insulin, they'll change the dose of insulin so that blood sugar rise doesn't happen. So that was the only usage of this device till before Bitterfly started its work in this area. So what we built was entirely different. What we built was correlating the food which you're eating and how it impacts your blood sugars. Like for example, here is a healthy meal where the blood sugar went from 104 to 131, which is a normal glycemic response. Versus here, where there is a unhealthy starch-laden food with lot of sugar, and the blood sugar went from 95 to 149 and remained there for almost 1 hour, which is like for a pre-diabetic person, ideally it should remain below 140 to be called it a healthy meal. Similarly, I found that whenever I eat bread, my blood sugars cross 150 and then they come down below 70 most of the times within 2 hours. Now, this is that typical high glycemic index food. I know about it in theory, but the moment I saw this happening in my body, I immediately changed my behavior. I gave up eating those noodles. I gave up eating bread. And I realized that the foods which are not pushing my blood sugar so much, those are the ones I should be adding. Then we termed this phenomena as personalized glycemic response, which means how much your blood sugars rise with each food, and it's different for different people. Now, in this audience, if I just take 10 people and give them the same food, same quantity, their blood sugars will rise to a different level. Currently, our diabetes management programs do not take into account this human variability. So we have created an engine called personalized glycemic response to take into account this variability and then plan the diabetes management accordingly. So I realized that the moment I go for a walking post meal, my blood sugars fall by 10%. If I eat salad before I eat chapati or rice, my blood sugars again don't rise so much. I was very fond of mangoes, but I was asked to stop mangoes. But what I did was, before I work out, I eat mangoes and then my blood sugars remain stable. So I discovered a lot of hacks, and as a result of this, my HbA1c came down from 6.2 to 5.5, and it has remained there. And I also understood that I need to do a little bit of weight loss, and overall it has resulted in a huge impact in my personal fitness and personal health issues. I come with a very strong family history of diabetes. I've lost 2 cousins to diabetic nephropathy. My dad has diabetes for last almost 40 years, and he has struggled with it, having MI and multiple other health conditions. So I didn't want to go down that route. So I hacked my way into the metabolism and discovered that this works really well for me. So once this was done, a couple of my friends who were endocrinologists, they came to me and they said, what are you doing to your body? We heard you're doing some experimentation. And I showed them what we had developed and they really loved it. And some of them asked me what you're doing. So I gave them this general theory that there's personalized glycemic response. If we can understand which food has how much of carbohydrates and how those carbohydrates are impacting the blood sugars, it can help people with diabetes control their blood sugar much better. Then I showed them this video also. So this is the video of blood sugar levels fluctuating throughout the day. And there is a meal with 42 grams of carbohydrates. Blood sugar went up, then came down. This is a healthy glycemic response. Then I was asked to take a oral hypoglycemic agent. My blood sugars were falling down early in the morning. I was having nighttime sweating and uncomfortable sleep. And then we also made a software which is called meal mapping, where you can see every single meal which you eat, how much of carbohydrate it has, how much of protein, fat, fiber, and then how much does it raise the blood sugar within next 1 hour. This is the glycemic response after each meals. And when we see this, then we can start making healthy choices. And once you make healthy choices, then automatically your blood sugars come in control. And this is different for different people. Last week, we were consulting some patients. Their blood sugars were rising with jawar and ragi. They were not rising with wheat. There are people whose blood sugars rise with certain fruits, certain foods, but not with other foods. So that's the kind of intelligence we built in. There's a lot of artificial intelligence involved in doing this. Then we took 10 patients and there were 2 nutritionists and initial outcomes were pretty good. 75% of the patients actually lowered their blood sugar. And then we created an app to do this for a lot of patients. But soon we realized that this is not enough. People with diabetes need a lot of other things to be done for them. So only diet plan is not enough. Though I may tell you this food is not good or bad, we need to motivate the people. We need to change their behavior. If you read the latest theories about chronic disease management, most of them focus around behavior change. Then almost 40% of our people who were coming to our program, they had back pain, they had knee pain, they had very poor fitness. So we added a fitness component. So this is the initial study which we presented at an International Diabetes Federation conference in December 2021, where we analyzed 300 patients on our programs and we understood their mental well-being status. We found that 66% of the patients are distressed because of diabetes. 30% are distressed because of the way doctors treat them. Like doctors like me, how we interact with our patient, it really impacts them. 28% have interpersonal distress and 35% have poor sleep quality. This is the first of its kind data coming from India, and this year we have presented another paper at American Diabetes Association, the first digital diabetes distress score data from India. Similarly, for fitness, we found 85% of people with diabetes had a BMI more than 23, and almost 60% had a BMI more than 25. People had very poor body strength, people had upper body strength, and very poor flexibility. This assessment was done in a very interesting way. We took the people on a Zoom or a Google Meet video call, and we used the American College of Sports Medicine guidelines, and then we created this fitness battery and assessed their fitness levels. So once we had this data that what are the mental problems or the, I would say, behavioral problems or stress or sleep issues with people, what are the fitness issues? Now let's combine what we have learned in nutrition with the mental well-being and with the fitness and bring a digital therapeutics technology to support people with all these kinds of things. So build a digital therapeutics platform. Currently we have 40 people, 40 engineers in the company who have worked on this for the last 2 years. This digital therapeutic platform has 3 components. There is a program design portal on the back end where we create therapies. So this is the first of its kind engine in entire, I would say, Southeast Asia, where you can design therapies not only for diabetes, but also for heart disease, asthma, osteoarthritis, and multiple other health conditions. We are already in the phase of launching obesity therapy. We launched it just 3 months back, and we are launching heart disease therapy within the next 6 months. So we see ourselves as a company which will design multiple digital therapies, helping people with better outcomes and partnering with doctors and pharma companies for this lifestyle management. Similarly, there's a patient app. You can all download the Fitterfly Wellness app. It is called Fitterfly Wellness. It's available on Android and iOS store. It has very good meal tracking, meal diary. You can see your own micronutrients like omega-3 fats, zinc for skin, for hair, for wellness. Then people who take up the membership program, they can get coaching in it. They can chat with the care team and they can get their diabetes under control. Thirdly, we have a backend coach app. So we have now 50 dietitians in the company, 20 psychologists and 20 physiotherapists who help the patients with various things, and they can interact with the patients real time using the backend coach app. So this whole comprehensive technology portal was developed in-house within our office. It's our intellectual property. Nothing has been copied from anywhere. So pretty exciting to create and innovate technology as you go along building. Plus, we have a human service team, which is comprised of experts who help the people with making those decisions. Now, let me show you how the program actually works. This program is called DiabeFly Digital Therapeutics Program. Patients log into the app, they pay online. Either we give them a continuous glucose monitoring device or we give them an AccuCheck instant glucometer, which is made by Roche. Once the patient joins the program, we collect data around medicine, diet, exercise, sleep, and stress patterns. We analyze this data, what is causing the blood sugar fluctuations, and then there are a set of corrective actions which can take place. The part of medication is handled by the doctors. We don't change medications. That is the domain of medical experts. But what food needs to be eaten, what kind of exercise, how to manage your pain, how to manage your sleep and stress, that all we take care of as a part of digital therapeutic system. In the therapy, we have personalized diet plans, we have mental well-being plans, we have fitness plans. There are coaches who interact with these patients over 3 months. They give consultations. And in the digital therapy, we send them 2 to 3 nudges and tasks every day. There are educational modules. There are a lot of video content, more than 3,000 videos. And there are live session and group therapy, which happen on a regular basis. Twice a week, they happen to help people understand their health condition and make those changes. Let me show you how impactful this can be. This was actually a patient referred by, this is a representational image. This is not the real image of the patient. So this 53-year-old female was referred to us with the HbA1c of 15%, which is very, very high HbA1c. She was on insulin, glimepiride, metformin, acarbose, and she had diabetes for almost 10 years. So when she joined us, in this CGM graph, you can see this is the 180 level. Her blood sugars are mostly above 180 throughout the period of 14 days. 56% of the time, the values are above 180. After a coaching, within a month, her blood sugars came down by almost 30-40%. And you can see this graph at the line of 180. only 27% of the blood sugars are above the range of 180. And within 3 months, her HbA1c decreased from 15 to 8.2. Her insulin dose reduced by almost 2/3. She could not even walk earlier. She started walking to almost 25 minutes. And she started monitoring herself more regularly. She understood that this is what she needs to do to get better results rather than keep on increasing medication. If you look at the amount of medication she was taking, practically everything she's taking. She's taking glimepiride, metformin, insulin, acarbose, practically everything under the sun. But ultimately, it is the digital therapeutic system which brought her blood sugar down. Another example, this is the picture of an actual person. This Captain Vaibhav Dalvi actually gave us the consent. His video is also available on internet. 51-year-old, HbA1c 9%. He was on multiple OHAs. He had high blood pressure also. And you see the kind of impact we can make. This is the meal before digital therapeutics, where he's taking a lot of carbohydrates, hardly any protein, hardly any fiber. But after that, showing him the data of how fiber affects the blood sugars, he made this change. He had very poor fitness and pain management. He had a lot of emotional distress and poor sleep quality, which we improved. And within a period of 3 months, his HbA1c came down from 9 to 6.8. And then he re-enrolled into a program and his HbA1c finally came down to 6.3. His weight reduced by 8 kgs and his fasting blood sugar came down from 150 to 120. And actually his doctor stopped all his medications within 6 months. We analyzed the results for 2021. People, 50% of our population came with a HbA1c of 8.5, which is a very high blood sugar. Like fasting will be more than 180. There, the HbA1c reduction happened by more than 3.2, which is astonishing. If you look at the most of pharmacological drugs, the HbA1c reduction is typically 0.75 to 1. Here it is happening like 3%, which is huge. In the range of 6.5 to 8.4, which is fairly controlled diabetes, the HbA1c reduction is comparable to pharmacological therapy, which is 0.9. Now, once you build this therapy and you have this kind of outcomes, the next logical step is, since we are a digital therapeutic company, is to generate this evidence, present it at the top conferences, and just make sure that people understand this is a therapy which is clinically proven and it works. So these are the results of the last 2 years. And we presented these results at International Diabetes Summit, International Diabetes Federation, American Association of Clinical Endocrinology, Endocrine Society of India, RSSTI, ATTD, Endo 2021. And just yesterday, we had 5 papers at American Diabetes Association, which is the largest number of papers by any private company in India ever at ADA. Let me take you through a couple of abstracts. This was the abstract which we presented at International Diabetes Federation 2021. Here, HbA1c reduced in 94%. Here we showed that the mean blood glucose reduction, time in range reduction, time above range reduction was quite high. And this is comparable to the pharmacotherapies which are available in India. Another one was change in dietary behavior. Here we saw that once the people are on digital therapeutic system, they were able to reduce their calories by 16%, carbohydrate intake by 18%, fat intake by 16%. 18% reduction in carbohydrate leads to 1.86% reduction in HbA1c. And there's a significant, all these values are very, very significant. At RSSTI last year, we presented the data from 202 patients where we showed the area under curve after a CGMS device. So one of the biggest problem which we found was that people, when they're eating evening snacks, they are choosing very unhealthy carbohydrate rich snacks. Here we could reduce the area under curve significantly in the snacking period and during the dinner hour, which led to an overall reduction in area under curve for the CGMS graph. Now, once we had built this and presented the evidence, it is very important that we help more and more people out there who are struggling with diabetes. Now, India, we call it the diabetes capital of the world. There are 77 million people with diabetes in India, which is 7.7 crores, and another 120 million who have pre-diabetes. So how do we use this therapy to impact more and more people. And even if you are all pharmacology graduates and students, you must have seen for any oral anti-diabetic drug, the first line in the description of the drug is this is an oral hypoglycemic agent used as an adjunct to lifestyle management or diet and exercise. Every single medication, whether it's metformin, whether it's dapagliflozin, whether it's SGLT inhibitor, you read about any medication, the first line description of medicine is this is used as an adjunct to lifestyle management. So if the lifestyle management is the primary management and pharmacology is second, then how do we create the system where lifestyle management becomes the first line of therapy? And we have an ambition as a company to impact millions of lives. This can change the way we look at diabetes in India. Rather than consuming all these drugs which are made in international countries and our GDP getting drained, can we make digital therapy at scale for millions of people, which can prevent the GDP loss, prevent, reverse, and manage diabetes for a lot of people, and lead to better productivity, better health, lesser complications like nephropathy, all those things in the future. So how do we do that? For that, we need to reach out to millions of people. So what we started doing is we started reaching to doctors. Currently, there are a lot of doctors who, just like the way they write a medication on a piece of paper, they write enroll in DiabeFly program. Now for doctors, it's very important because we support their patients beyond clinic. So patient leaves the doctor's clinic, he gets a digital therapeutic program, then we send the reports back to the doctor. We ensure that the patients take the right dose of medication at the right time. We ensure better outcomes, and doctors get the data back if they need to reduce the medication, change the medication. And if you even look at the abstracts which we are presenting in American Diabetes Association, 30 doctors partnered with us for research also. So it's a great value add for the doctors. But winning the doctor's trust is not easy. You will all go and work in various pharma companies post your graduation. You will realize winning the doctor's trust is not easy. Doctors are worried about the data privacy. They want to know if the outcomes are genuine. And the biggest worries will be take away their patients. So there we tell them that we are clinically validated. This is a doctor, super specialist doctor who's running the company. So all the data privacy things are taken care of. We partner with them. So till now, we have more than 150 doctors across India, the topmost names who refer us patients. We have published a lot of abstracts and we have won a lot of awards also. And within diabetes, we found that people who have a newly diagnosed diabetes, people who are struggling with high HbA1cs, people where the oral hypoglycemic agents have failed and insulin is getting started, and people with diabesity, which is a combination of diabetes and obesity, are the best kind of patients to enroll into such a program, and they are motivated because ultimately for digital therapy, they have to be motivated. It's not like a tablet which is just easy to sip with a glass of water. They'll have to invest 30 minutes every day into changing their lifestyle and actually make those changes consistently over a period of time to achieve outcomes. We also are very active on Google and Facebook. If you go and just type Vitafly anywhere, you will find our news, our views, a lot of videos. Our videos generate a lot of views on YouTube. They're actual genuine stories of people. We go to patients' home and shoot the videos with them to see what change have they made. We do a lot of news and press articles because we believe people need to know about this therapy. And that's a very important way of generating trust when you appear in the newspapers. We've also started working with a lot of organizations. We are working with Tata Steel, Unilever, Nestle for employee wellness. We are also working with some insurers where we are asking for outcome-based payment. And we have worked with pharma companies like Sun Pharma, Torrent, USV, where the pharma company goes to the doctor and tells them that while you're prescribing a medication, if your patient needs lifestyle management, here is the program and the pharma company pays for it. So that also we are doing. So all these things put together, we have an ambition to impact millions of people. And for me, the story is ongoing. For me, this is a mission for the next 5 years. We want to keep on improving our app. We want to keep improving engagement. We are integrating more devices like BP machines, fitness trackers. We are striking more of partnerships. We are getting a lot of interest from Gulf regions and Southeast Asia for launching this program in other countries, and we will be working towards that in the next 2 to 3 years to launch this therapy in multiple countries. Can everybody please mute their mics? I can hear people coughing. It just disturbs the flow. Also, one of the important things, a recent report from one consulting company in UK came out. which showed that digital therapeutics will overtake the prescription pharma drugs by 2035. The amount of money invested or the revenue generated in digital therapeutics will be higher than the pharma industry in next 10 years. So that's very exciting. And one of the things which we are very fond of saying in the company is, you may be using technology for currently making self-driving cars or rockets to the moon, but the real technology usage is for improving human health and for improving human health outcomes. So that's what we are investing in. And thank you very much for giving me time. I hope I've motivated some of the graduates here, some of the people here to think about digital therapy very differently than the standard pharma therapy which we think of. And in our company, there are 3 pharmacology graduates who have joined us. One of them has joined us designing hypertension program. One of them has designing obesity programs. So, in pharma, we think of everything like a therapy. We test a molecule, there's a clinical trial, then there is a proper phase 1, phase 2, and finally real world trial which happens, then we launch the therapy. So we also design the therapy in a similar way. Though it's not a molecule, we call it a digital molecule. It's a digital therapy which is tested, which is proven, which is used, and which has outcomes. So it's very analogous to what we do in pharmacology. So very happy to answer any questions, any doubts if anybody has. I'm sure this is thought-provoking, and a lot of people here might be having some questions for me.
Any questions from the delegate side, please?
Madam, I have a question.
Please proceed, sir.
Yeah, it was a fantastic presentation and very exciting journey of sirs. I have one question regarding telemedicine and online consultation. The medical legal, declarations of the government keep on changing, and sometimes they become very unpredictable. So how do you cope with that?
So fortunately, thanks for the question. That's a wonderful question. Only constant is change. And being in a technology company, we are very adapt to change. Fortunately, the dietitian, psychology, and physiotherapy consultations do not lie in the regulatory space. There's no regulation which governs us. We don't do doctor consultations currently, and if the doctors are going to do consultation, they'll have their own set of regulations to follow. So currently, the consultations which we do, since we do not prescribe any medications, we are not covered by telemedicine laws. So it doesn't affect us.
Yeah. Thank you, sir. Thank you very much.
Thank you, sir, for that question.
So there is one question in the chat box. What's the membership cost of the app?
It's very cheap currently. If I tell you, you'll all be shocked. So for a diabetes 3-month program, we charge about 1,600 rupees a month, which includes full psychology, physiotherapy, and nutrition advisory. So about 5,000 rupees for 3 months. If they take a CGMS device along with, which is available in 30 cities now with us, that is 9,500, including the device, including the coaching for 3 months.
So what's the importance of using digital therapy in improving health?
I think we have to think about it very differently. The biggest problem in any chronic disease, whether it's hypertension, diabetes, obesity, PCOS, is making those small changes in your life every day. Like if you're presented 2 foods, which food will you eat? If you have to make a decision for your lunch, which lunch would you take? If you get up in the morning and you have 30 minutes, will you spend your time on Facebook or will you go for a walk? If it's 10 p.m. and you have to get up at 6 a.m. for a class or a walk, will you watch another episode of Family Man on Netflix or Amazon Prime, or would you go to sleep and do that on Sunday? These are basic choices which impact our health outcomes. And if we can create a digital therapy which can help people making 80%, see, there is cheating involved in everything. You should cheat. Once a week, twice a week, doesn't matter. You eat pani puri, chole bhature, it's not going to impact you. The human system is malleable enough to take care of those variations. But if you end up making right health decisions 80% of the time, you'll see a significantly better outcome, whether it's weight loss, whether it's better skin, better hair. I know there are a lot of girls here, so I'm mentioning out there. And whether it's diabetes, PCOS, everything is impacted by these small decisions. And these small decisions you cannot do by yourself. Even if a doctor tells you to eat healthy, sleep on time, go for a walk, It goes on in from here, it goes out from here. But if there's a digital system which is allowing you to track your health, make those small decisions, and show the improvement on a consistent basis and gamify it, you'll end up making that change because there is an accountability system built in. So I think digital health should actually be the first line of therapy for most of the health condition, rather than going to a pharmacotherapy first. Now, for our setup cohort, there are about 20% patients who take up initially only digital therapy, but 80% need pharmacotherapy. So I'm not saying pharmacotherapy is redundant. It remains a port of call and a very important choice. But a lot of other conditions where we are adjunct or we are helping the first line therapy, I think that is how we should think about digital therapy. There is no way we can produce enough drugs or enough everything which we are doing currently. See, pharmacotherapy, doctors, hospitals, diagnostics have been there for last 40 years. Has the diabetes incidence come down? And if I ask you honestly, the way we are going currently, do you people think diabetes will ever decrease? The clear answer is no, it's only going to worsen, right? More people will get diabetes, the lifestyle is changing, it's an erratic lifestyle, people don't sleep well, people don't know what to eat. So it is very important that we use digital therapy as the first line of therapy to make a significant dent in the diabetes trajectory, which is going to happen. So that's how I think about the overall approach to digital therapy.
So there's one more question: how to combat sedentary lifestyle, as most of the doctors cannot escape it?
Oh, this is very, very interesting question. This is super interesting. I'll tell you a story. So we signed up a project with Sun Pharma where we took 1100 doctors for digital therapy. Only 35% of the doctors were active. 60% were overweight. 30% had diabetes. And out of those 30%, 50% had poorly controlled diabetes. Can you imagine? Like, these are the doctors and all of them were MBBS upwards. So it was an eye opener for us. Then we started working with doctors because we realized doctors live an extreme life. I'm a pediatric urologist. I still do surgeries 2 days a week. It's crazy. I start my surgeries at 7. I'm finishing at 5. Sometimes I'm not getting lunch on time. Patient relatives are consuming too much of time. It's a complicated case. It's a horrible, stress on the overall body which happens. But then I realized that if I work out 30 minutes, even on the OT day, my whole day goes well and I'm healthier. My blood sugars are better in control. So doctors think that they're working hard and that is enough as an exercise. They go for a one clinical round or they are sitting in the clinic or they're standing. That is not exercise. Exercise is whole body exercise. And what it needs is just 15 to 20 minutes per day. And that is a behavior change. So one of the things which I did was that I used to keep my gym bag ready the night before next to my bed. So when I get up from the bed, the first thing is see is the water bottle in the gym bag. So at least one decision is done and the socks are ready, the shoes are ready, the water bottle is ready. You know that one friction point is gone. So I think as a doctor, we have to build a system which doesn't allow us to make decisions. It becomes an automated behavior. So I think that is the only way we'll be able to overcome the sedentary lifestyle. And another thing which I did is whenever I get any phone call, I stand up and start walking. This is known in my house that Arbinder ki phone call aayi to wo utھ ke chalna chalu kar dega. Everybody knows I'm pacing around. Even in this small conference room, I'll do 50 rounds over 15 minutes. And I check my every day evening that I've done my 5,000-10,000 steps. I've done my 30 minutes of physical workout. So I think we'll have to be smarter about it. Even while patient consultation, these days I do a lot of consultations while standing. Patient is sitting, but I'm standing by their side and I'm moving around in the room just to include physical activity.
Any more questions from the delegate side? So there is a applaud from Dr. Nandini T. Sir, it's like a best and overall approach, pushing the drug down the list. Superb, sir, great going. Thank you, sir.
I saw that comment. And also, how is the primary care physician? So if you go to the Fitterfly page, there is a special page for doctors who want to work with us as partners and make sure that patients are helped for better outcomes. You can just submit a query there and one of our team members will call you, give a technical demo, and then we can definitely work together.
Sir, are the algorithms in this are personalized, sir?
Yeah, absolutely. So the algorithms are so personalized. Let me take two different examples. So suppose there are two people with diabetes, type 2 diabetes. There is one person A, who lives in Bombay. His BMI is about 25. He travels a lot, and he's a vegetarian, and he has high blood pressure also, and he has diabetes for 10 years. His therapy will be very different from a person who's living in Kanpur, is eating only vegetarian, doesn't have hypertension, doesn't travel much, and has a normal BMI. So a person who has a high BMI, he will get a lot of messages and a lot of communication and coaching around losing weight. Person with a normal BMI we not talk about much about weight loss. Now there may be a person who is on oral hypoglycemic agent, which is a SGLT inhibitor, which we know causes higher risk of urinary tract infection. So he will get coaching about prevention of urinary tract infection. Versus a person who is on insulin, then we will teach him about how to take insulin properly, how to rotate the insulin sites, how to preserve and store insulin, how to do the carbohydrate counting, all that is done. So it is so personalized, we call it the labeling system. When any person joins our program, we apply labels to them. Within our system, we have more than 500 labels. After the first profiling, we label the person. This is a type 2 diabetic on insulin, high stress level, poor fitness, is on oral hypoglycemic agent, has a high BMI. Automatically, the therapy starts working along those lines to cover those labels. So it's super personalized, and that's the biggest innovation which we have achieved building this digital therapeutic system. There's a question about non-diabetic people. Yes, we have a lot of people who use our app for checking micronutrients for hair, skin. We have an obesity program also running for people who want to lose weight. It is a intensive behavioral therapy, IBT based weight loss program, where it's a psychology first program, more psychology consultations than the dietitian consultation. That's called Reset 23, which is resetting your BMI towards 23. So that's also available right now. Will this approach help in diabetic patients with complications? So if it is, so there is one complication which we are little, I would say the system is not geared up to deal remotely, which is mid to late stage kidney failure. There people require a lot of fluid restriction, diet restriction, frequent visit for either dialysis or checkup. Those kind of patients we don't take. But somebody, suppose a patient had a retinopathy or a foot ulcer and all those things, we take those patients and manage their diabetes, because in those patients also, or stage 1 kidney disease, in those patients, whatever is required in terms of bringing their blood sugars down, we are able to manage. But once they go into low creatinine clearance, then we don't take them on a digital system. They have to go and see physical healthcare.
Any more questions from the delegate side? Thank you, delegates, for your active participation. So thank you, Dr. Arbinder Singhal, sir, for sharing your vast experience in the industry and latest updates in the digital therapeutics. I'm sure this will be of great help if we inculcate the technology in managing diabetes. Thank you so much, sir.
Thank you, ma'am. Just one last thing which I wanted to say, we have some internships also running. If people wanted, pharmacology graduates want to, do some internships or something, I'll just put my email address there. We'll be happy to have internships or research projects or anything, whatever helps the students in understanding digital health better.
Thank you so much, sir. This would be of great help for the PGs.
Thank you, ma'am.
Thank you for joining us, sir. We will have a tea break for around 10 minutes. We'll gather back at 12:30 for the next session. Dear delegates, please join us again. I'm sure you'll have the academic feast in the further sessions too.
Hi, ma'am. Sorry.
Hi, ma'am.
Hello,
Ma'am,
hi.
we'll start the session, ma'am.
Yeah, okay, 1 second.
I'll give a small introduction about you, ma'am. Later we'll start, ma'am.
Yeah, fine.
Now let us move on to the fourth session of today, current status of diabetes mellitus in children. I am privileged to introduce you, ma'am. Dr. Shaila, ma'am, is MD Pediatric from GIMS, Hubli, the prestigious institute from Karnataka. She has done fellowship in pediatric endocrinology at Indira Gandhi Institute of Child Health, Bangalore, Karnataka in 2017. Madam has around 5+ years of experience in pediatric endocrinology, and presently, Madam is the pediatric endocrinologist in Department of Pediatrics, JNMC, Belgaum. Over to you, ma'am.
Okay. Thank you, ma'am. Thanks for giving an opportunity to present myself in this platform. So my slides are visible. Huh? Hello.
Ma'am, they are yet to come, ma'am.
Yeah, fine.
Yes, ma'am, we can see your slides, ma'am.
Okay. So thank you. So my topic will be on the current status of diabetes mellitus in children. So before going into the topic proper, I want to discuss 2 case scenarios here. In the first case scenario, we have a 17-year-old girl who was diagnosed to have type 1 diabetes since last 10 years, and she was on injection mixture 20 units and 10 units in the night. She's short, she has developed neuropathy and even nephropathy also. Parents are worried, what will happen to my kid? In the second case, we have another girl who is 13-year-old, diagnosed with type 1 diabetes since last 2 years. She's an athlete and she was started on basal bolus regimen initially, but with a poor compliance. Her HbA1c was 13%. It was affecting her passion. So the doctors have advised her CGMS and insulin pump, or to continue the same basal bolus regimen along with the CGMS. And she was taught about the carb counts, and her recent HbA1c was 7.6%. We have 2 different cases here. One which was diagnosed few years back, and she's been on injection mixture with a poor control, and she's into complications. And we have another second girl who is being managed very well with a comprehensive management was done by the doctors. So what has happened in the few years we'll be discussing later. So coming to the type 1 diabetes, we all know it accounts for more than 94% of the diabetes mellitus in children and adolescents. It's a chronic disease. It requires a lifelong insulin, and that too in the form of subcutaneous injections. It's like insulin was discovered in 1921. Almost we have reached 100 years of insulin treatment. It's a new milestone. Before that, all the children who were diagnosed to have type 1 diabetes, they were like just managed with the diet. They were told like no treatment is there and all that. Within few months or few days, kids used to die. So this insulin discovery has made a tremendous improvement in the management of type 1 diabetes. So why we are worried so much about this type 1 diabetes and insulin and all that? Because it has its own short-term and long-term complications, which are both micro and macrovascular complications. So over the years, the newer management strategies have come, which are important for the optimization of the treatment and also for the better survival. So we can ask what is the prevalence? Why we are so much worried? In India, prevalence is more than 10 per 1 million. And every year the prevalence is increasing, and it may vary based on the ethnicity, geographical location, age, gender, and family history. In Karnataka per se, recent guidelines says around 3.8 to 4 per lakh is the prevalence. And type 2 also we all know, because of sedentary lifestyle, it has been discussed in the previous presentations. It is increasing even in children also. So what are the etiology? Just we'll discuss this part so that we'll have an idea what strategies have been taken to prevent this occurrence of type 1 diabetes. So we all know there should be some genetic susceptibility. So there can be something like HLA linked or some genetic genes. More than 60 genes have been contributing for the occurrence of type 1 diabetes. Not only the presence of genetic factors matter, sorry. Along with that, some triggering insult should be there in the form of environmental factors. That can be viruses. Even now, recently, even the COVID viruses can initiate that attack. It can be any diet or the drugs or the chemicals. Even the alteration of the host microbiome can cause this. So those who have a genetic factors, along with that, the triggering insult, this will cause failure of the cell tolerance, and it keeps causing destruction of the beta cells of the pancreas. The new word which is used is assisted suicide. Over a time, it will cause insulinopenia and type 1 diabetes. When more than 90% of the beta cells are damaged, then only the symptoms will come. So, okay, coming to the bit of history of insulin. Initially, few years back, somewhere around the 18th and 19th century, they found that some two scientists, they tried extracting the pancreas out of a dog body, and they found that the dog died after a few days because of glucosuria. And they came to know that pancreas has a source of some glucose controlling area, which they were not knowing. Finally, in 1921, insulin was found by Banting and the Best. And then over the years, initially it was actually the porcine and the bovine insulin were used because there are a lot of side effects that and a lot of allergy happened to that. In 1975, they started with the recombinant insulin. Over the years, they started getting a newer analogs, like where they modified some amino acids and they wanted for a better long-term action of insulin. So the analogs came. Then the inhaled insulin came, the somewhat in the form of Apriza or the Exubera, but not we use in children. We have oral or the buccal insulin. Okay, and initially the pump was introduced in that concept came in 1963, and also in 1970 the first pump came, and initially the pump was so big, it was like it is like you were carrying a bag. Over the years, the pump size have come, and it is like almost like a phone or a pager. Even the basal bolus concept came, and then Novo Nordisk, they introduced the insulin pen delivery system in 1988. So coming to the regimens, over a time they have changed. Initially, pre-mixed insulin preparations were used. It has a fixed ratio of pre-meal and basal insulin. It used to come in the ratio of 30s to 70, 50s to 50. That, but it didn't give any good flexibility. Okay? Like we'll not be having food every time the same quantity or the same proportions and all that. But this preparation, this method was not flexible, but it was good for those who were not willing to take more injections. But it had a poor metabolic control. These are the various drugs which comes like in 30s to 70, either in the cartridge or in the pen form. But truly said, it is not preferred in children because they are not a good control. Then they will not be having a good control of sugars. Next came the split mix regimen. Here also we have a combination of the short acting and the long acting. But here we separately take both the insulin and then we mix it and give. It is also okay compared to the mixed regimen. But the action of NPH is unpredictable. And when we give it in the night, like around 7:30 in the evening, we can have an expect hypoglycemia in the midnight. So, and NPH also has an unpredictable action. Sometimes it will act more and all that. So now the recent regimen, we all are aware of that. Since anything. So recently we are using this basal bolus regimen. It has one drug we use in the baseline, and the other 3 drugs which we use along with the meals. The concept is clear. When we are fasting, there will be some amount of insulin secreting from the pancreas into the portal vein in a basal manner. That we are taking care by giving a long acting or an intermediate acting drugs which will act slowly in the background. And with the meals, we are giving 3 boluses, either in the form of short acting drugs or a rapid acting drugs, and that is which occurs even inside our body. We can use this basal bolus regimen by multiple daily injections or through the insulin pumps. This even the NPH can be used here. So we all are aware of these syringes. Initially, the syringes were of length were of 8 to 13 millimeter. Now recently we have a very small needles where it's 4 to 6 millimeter. Even the gauge is like 31, 32 gauge. It causes less pain. Now the introduction of pens has become more flexible, but the cost is an issue. the recent introduction was about iPort. This iPort is something called as there'll be some device, inserter device, which will insert this iPort into the skin, so that it has its catheter. I think it is seen here, the soft cannula which will pierce the skin. Here in the upper portion, we can inject the insulin through either through a syringe or a pen, and this will deliver the injection into the subcutaneous tissue. It can be changed every 3 days. Otherwise, we have to give multiple injections throughout the day, but this iPort will help in reduction of the multiple pricks. So coming to the blood glucose monitoring, we just let us know about the two main words here. One is CGMS, that is continuous glucose monitoring system, which has been discussed in detail in previous presentations. Then about the SMBG, that's a self-monitoring of blood glucose, which we usually do with the glucometers, and there are a lot of glucometers available in the market, and we have to choose which is the best one. But shouldn't be doing a FBS and PPBS every 3 months, which we do it in type 2 diabetes, because in type 1 diabetes, the blood sugar variation is much more than which occurs in type 2 diabetes. Brief about CGMS. So this is how the CGMS looks like. It has a pad. It has got a sensor which is inserted into the skin, which will record the blood sugars in the interstitial tissue, not the capillaries. Then we have either transmitter, or it is a wirelessly connected into the display device. It can be either a phone or a watch, which can be worn on the hand. So what it does, it records sugars every 1 to 15 minutes based on the different companies which are available. And as I said, it measures the interstitial blood glucose. There are two types. One is a retrospective, or other is a real time. Retrospective means it will record the sugars in the last 10 days or 14 days, but it will not help in adjusting the insulin at that time. But the real time CGMS is like, we'll record the sugars and we can adjust the insulin dose. We can change our food intake and all that. So real time CGMS is much better than the retrospective. And we have various CGMS devices available in the market based on their various costs are available. And some are worth for 10 days, some are worth for 14 days and all that. So when we use real time CGMS, it will help us in reaching the target HbA1c, and also it reduces the glucose variability, because in any patient, if the sugars are something like 50 one time, it will be something like 500 sometimes, 200 and all that. So much of variable glucose is more dangerous than a persistently high sugar or a persistently low sugar. To avoid this glucose variability, this CGMS will help. And also it will help in maintaining the time in range in the pediatric population. So we'll discuss about the time in range. What is that time in range? It is how much time it is spent, the blood sugars are spent in between the 70 to 180. So how do we do that? We calculate it from either CGMS or a finger prick, especially when you've done more than 4 times per day. It gives a better picture of frequency of having a high or a low blood glucose. See, in this image, we can make out that the target range we have kept as 70 to 180. In this patient, they are maintaining it more than 70%, which is actually ideal. The time in range, we have to maintain more than 70%, and less number of hypos and less number of hypers. So recently people are changing from HbA1c to time in range. At least we have to maintain the blood sugars normal most of the time in a day. Here you can see this is a normal one. In this patient, 55% are in the normal range. Remaining, there are many high values and many low values, and this requires some comprehensive management. Here also we can see, here, see, look at the graph. All the sugars are at a higher level. None of them in the normal range. It's 0% time in range. Here 50% are normal and 50% are high. Here almost 100% time in range. This is how we get a CGMS report. And the CGMS will be worn, as I said, for 10 or 15 days. In this report, it will mention how many days the CGMS was worn, and percentage of time the CGMS is active is also, it was given in the displayed in the report. And it will averagely says what was the glucose, and average it will help in estimates the HbA1c, and also about the coefficient of variation. if you have like a normal sugar, how far apart the glucose values are varying, and also how far the values are from the average. It will be given in that. In this image, you can make out here that it was bored for about 14.5 days. Then it was active for some 70% of the time. And CGMS is reliable only when it is active for more than 70% of the time. And what was the average blood glucose and estimated HbA1c and all that. These are the various CGMS which are available. This is the port which will be wore, and this is how it is displaying. The cost will vary, but it doesn't come with without any side effects. The probe, the insert, the probe can have an skin irritation. It can have an allergy. Because of the embarrassment of wearing device, the patients may ignore it, or they can have sleep disruption because of the constant awareness of the wearing a device. Now coming to the insulin pumps. It is also the other word which is used for that is continuous subcutaneous insulin infusion. So it also helps in achieving a target glycemic control. And when we use the CGMS with the insulin pump, we have a better control. It also helps in the reduction of the hypos and the glycemic variability. So this is how the insulin pump looks. Here, this is a device which has a socket for putting an insulin cartridge. It is delivering insulin through a tubing into a port. And this is port which has to be changed every 3 days. Otherwise, there can be lipohypertrophy at the single site. It's a battery operated device. We have, it's like operating a mobile. We can adjust whatever we want. And it's more comfortable. And in this insulin pump, we can use only regular or a rapid acting insulins, which are like once you stop the insulin infusion, the action terminates fast. That's why we wanted a very short acting drugs. How would you deliver insulin in this? In the basal bolus regimen, we give 3 boluses with a meal and 1 baseline. Here also we have the same thing. We have a basal, we give it in a basal rate. Then with the meals, whenever the child is having meals, we can give there are various types how we deliver boluses. Standard is a one where we deliver all the insulin at a time, like when the child is having some amount of food and all that. When they're having some mixed diet, they're having something called as a fat along with the carbohydrate, they're having a fat, which will delay the absorption of carbohydrates. We want the insulin to act for some times. So we usually combine the standard with the square. We give a dual bolus. Square when the child is having food for some times. So based on the requirement of the child, the boluses are delivered. And whenever there is some hyperglycemia, we give a correction bolus so that we get all the sugars in the time like range, like 70 to 180. So that we can have avoid hyperglycemia and a better control. So as I discussed, we can have a different basal rates. See, in basal bolus regimen, we give a 1 injection at night that will be delivering insulin throughout the day. But in insulin pump, we have an option of setting a different rate. Like we may require less insulin in the midnight. We may require more basal insulin in the morning. So we can have a different basal rate as per the activity, as per the days, timing of the day and all that. And with the insulin pump, we can give very minimal dose also. And as I said, different pattern of meal boluses we can include for the various food ingredients. And there are recent insulin pumps have come with such an idea that whenever sugar is falling down, they stop the insulin or they reduce the insulin. Something called a smart guard mechanism. So, but we cannot give insulin pump for every patient. We have to carefully select the patient because they should be aware of what are the parts of an insulin pump. They should be educated. They should be knowing how to operate that. And they should be able to monitor the blood glucose along with that, so that they have to correlate the CGMS data and they have to correlate the blood sugar. They have to see the carb counts and all that. Then only they'll be able to use the insulin pump. Only advantage it gives is it gives a flexible lifestyle. And problem with this is whenever they have got some hyperglycemia and they have to give a correction, in case the pump stops, the parents have to be ready to use a pen or a cartridge. Cost is enormous actually. Here, I'm showing here. This is how we actually use an insulin pump. we combine with the CGMS. The recent insulin pump have come that like using a CGMS to help in adjusting the insulin pump. Here we can see there is on the right side, there is a sensor which will be detecting the sugars continuously, and this will be transmitted wirelessly into the insulin pump or using some phone. We are using some technology. It will have some insulin algorithm and it will tell the insulin pump so much of insulin is required. This is how it is worked. This is a sensor which will say this much of sugar is there, and it will wirelessly send the link information into the pump, and it will deliver the required amount of insulin to the skin. The the various insulin pump have got an approach like excess of entering how much of amount of carbs we are taking, how much of was the sugar which was the previous day, and how much insulin we want to do, and if you're doing any exercise, this all will be can be entered in the insulin pump, and it will help in delivering the so much of insulin to the body. So what is artificial pancreas? It's nothing but the insulin pump only. It's a closed loop. We use the sensor, then we use the insulin pump, which will deliver the insulin to the body. What happens when we eat food? Same thing happens. Like we eat the food, it will tell that so much of sugar has come into the body. The pancreas will release so much of insulin into the body, and the sugars will be controlled. Same thing, we are doing it from outside. What about the dual chamber pump? In the dual chamber, insulin is a must, and the second one will be either a glucagon or a amylin. Like in our body, whenever we have food, they can be like when we are not having food, they can be hypoglycemia, or when we are having food, they can be hyperglycemia. So we want both insulin and glucagon. In the dual chamber, they are using both insulin and glucagon so that the sugars are in a normal range. So next comes about the post-insulin, beyond insulin. So the newer advancement, it's been not newer advancement in many years. The people have tried a pancreatic transplant. They have tried the whole pancreas, and there's a good response in terms of insulin independence, but not many, around 60% independence after 5 years. Even just tried with islet cell transplant, it's better than that. But for islet cell, we want many number of cells. The donor is an issue and also a cost. In a lot of intervention trials have occurred to prevent, rather than the treatment of the diabetes, the prevention trials have occurred. For example, if one child is diagnosed to have diabetes in one family, the parents may worry the other child can also have a diabetes. How to do that? And they found that the child has got antibody positive. So how to go ahead about that? They have come with so like, sorry, many parents have come with the doubts, like can we prevent the type 1 diabetes in the other child? For that, many trials have been occurred. They have occurred at various stages. In the first stage, people have tried to prevent or delay the destruction of the functional beta cells. How they have tried is by immunomodulatory intervention or some disease modifying means. In the second step, like whatever the diseases occurred, now they are trying to preserve the whatever remaining beta cell mass is there, so that they can manage with a little bit of exogenous insulin. In the third step, the diabetes has occurred, nothing can be done. Now they're trying to reduce the long-term complications, especially the cardiovascular and the renal, which are the most common cause of morbidity and mortality. So the newer, like the tick screening and the good glycemic control using CGMS or the basal bolus or the insulin pump. First one is the prevention or delaying the destruction of functional beta cell mass. What happens? We have T cells, we have B cells, number of drugs have been tried. The list is enormous. I'm not going into detail of that. Like they've tried to prevent the T effector cells action. They're trying to prevent the B cells so that the lot of antibodies are not against the acting against the pancreas. And like we use in rheumatoid arthritis, the infliximab, and in immunomodulator drugs, they have been tried, but none of them are actually helpful in preventing the destruction. Next, when we target either the T cells or the B cells, it comes with the risk of long-term or irreversible changes in the immune system. And we are inviting ourselves for the chronic viral infections. Next comes about like some studies have tried so that they have given insulin or the GAD65 as an antigen, like we give vaccines. Same way they have given this, and so that they want to the body to tolerate these antigens and doesn't act against these things. So like it's like endures tolerance to that, but also it has come with not much good results are there. It's mainly because to avoid the damage to the T cells, they have tried this one. There are a lot of other drugs, the non-immunomodulatory adjunctives. It's been discussed in the previous talks. The SGLT inhibition, the GLP-1 agonism, and other drugs. We'll be discussing about this now. The amylin, it actually inhibits the glucagon. So it mainly reduces the postprandial hyperglycemias. Metformin, all of us are available. It is not much improvement type 1 diabetes. Only we can use whenever we have someone has insulin resistance, especially those with obesity or overweight. But otherwise, please do not use metformin in type 1 diabetes unless we have a sufficient evidence. And the third drug is like SGLT inhibitors. Sorry. Inhibits the absorption of glucose in the intestine and also causes glucosuria. The trials are going in still, but actually they are more useful in type 2 diabetes and also those who are overweight or the obese. The next is the GLP-1 agonist, like liraglutide and all that. They are also mainly for type 2 diabetes. They help in reduction of weight and the postprandial sugars. There are studies who are trying this metformin, SGLT and GLP-1 agonist. Will we have a sufficient evidence? Please do not use them. And type 2 diabetes is discussed. We all know it is increasing in the recent thing. Metabolic syndromes like sedentary lifestyle, excessive screen time. It is also causing a lot of type 2 diabetes in adolescent children. Still, type 1 diabetes accounts for the majority of diabetes. So the few more about the monogenic diabetes, it still accounts for 1 to 4% of diabetes. These diabetes are not because of the autoimmune destruction. There is some problem in the development or function of the beta cells. And why we have to differentiate these from the type 1 diabetes is only few of them require insulin. Some of them will be managed even with the oral sulfonylureas. Some of them just doesn't require any treatment. We have to do our genetic studies, which will help in management and genetic counseling. Then the neonatal diabetes mellitus, we'll see a lot of neonatal diabetes mellitus. They are diagnosed in the first 6 months of life. They are also actually monogenic diabetes only. They occur because of the abnormal pancreatic development or a beta cell function or a beta cell destruction. They usually have some syndromic associations, and most commonly, like we have seen ABCC8 and KCNJ gene mutations. They actually respond to oral sulfonylureas. In the last month only, we shifted one of the child, a 7.5-month-old child, from insulin to sulfonylureas, and this child is maintaining excellently normal blood sugars, and that was secondary to ABCC8. In many of, in India, one lab in Chennai, I cannot mention the name, they are doing genetic screening free of cost. So please, I request all of you, those who have got diabetes in the first 6 months of life, please get a new genetic screening for that. If you find it's a ABCC8 or KCNJ mutation, we can try with the sulfonylureas. As I said, the differentiating type 1, type 2 diabetes from the monogenic diabetes is important. Like I should say, thanks to the improvement in technology, we are able to diagnose them. And as I said, it's done free of cost in few labs. So few lines about the management of diabetes, because I think it is a must. Like everyone start the treatment at home. That's not the thing. First, hospitalize all the children for initial management and education, and start insulin therapy at diagnosis. And if have any intercurrent infection, treat with antibiotics. We have to stabilize the DKA. We have to involve the whole family. We have to give support to them, and we have to teach the older kids for self-management of diabetes, including hypoglycemia and sick day management, and to teach them the practical skills. Not a single thing. Nowadays, over a days, it has evolved that it should be a multidisciplinary team. The one who is expertise in pediatric diabetes, we should have an educator. We have a nutritionist and psychologist in our own ISPI, and we are training the diabetes educator every 3 months. We are having a training sessions for diabetic educators, so that it's not the burden shouldn't come only on the pediatrician or the pediatric endocrinologist. the educators should also involve in the management of diabetes. And please avoid the alternate therapies and maintain a logbook. Word comes, it's ambulatory management, the 4 therapeutic pillars of diabetes management, the diet, the exercise, medication, that's the insulin. And without the monitoring of sugars, we cannot assure a good control of diabetes. This is how one of my patients has sugars. Here you can see that in this day, almost all the sugars are in the normal range. Here also almost, except 1 value is on the higher side. In this also 2 values are on the higher side. Like as I discussed, time in range, almost at least more than 70% in the normal range. Few of them like can be on the higher or the lower side, but this is how they maintain the logbook. It's an important part of diabetes management. They also maintain how many units of insulin was given, what is the food they have taken and all that. I think all of you are aware about the insulin to carb ratio. Like nowadays, everyone is aware that we cannot just have a diet. We should be aware how much of carbs we are taking. For that, how much of insulin has to be taken. So they should be aware of the insulin to carb ratio. And we have got some sugar value in the blood. You should be aware like how much of sugars it is taken care by 1 unit of insulin. So we have the word for that, like insulin sensitive factor. You're all aware of these problems. I think I'll skip this page. Without a diet, we actually call it a medical nutritional therapy, because the adult is different. The pediatric, we have to match their insulin, we have to match their exercise and meals. In pediatrics, development, growth and development is an important part. We cannot say you have to avoid carbohydrates. We have to give adequate carbohydrates, and we have to, at the same time, we have to make sure that child is growing adequately and make sure it's not hyperglycemia, because hypo is detrimental to the brain of the child, and there is no separate diet for kids. Involve the whole family and give the energy as per the age recommendation and based on the food, local, economic and religious grounds. In the previous things, they used to tell don't take more of carbohydrates. Now we are more liberal to them. We are saying take, but whatever you take, maintain this ratio. That carbs should be 50 to 60%, protein should be 15-20%, and fat should be 30 to 35%. That's a must, and we should have an age appropriate protein intake so that we're not avoiding any of the the child should be having the adequate diet as any other child has. And avoid salt intake, and please do not prescribe any vitamins or minerals unless it is actually required. And we all know about the glycemic index. Like when we take a sugar, it suddenly increases the blood sugar. Like it is like, how fast it will increase the blood sugar. That is taken for a sugar is taken as 100. Like, these are the various glycemic index of various foods. Actually, we prefer a low glycemic index. The white bread, the white rice, the potato and all that, they have got a very high glycemic index, and we have to try to avoid them or combine them with some drugs, some food which can reduce the effect of this. And next, coming to the carbohydrate count, like I can make out in this whole chart, it's mentioned the rice has got 60 carbs gram, this puri has got 10 gram, the sabji has got 5, 10, 2, 3 and all that. Lot of PDF documents are available, lot of Android applications are available so that we can teach. I actually give parents one measuring cups. It's not that costly it's available easily in the Amazon or in the, like we can get in the outside, like people prepare with a lot of ice creams and all that. No, we have some measuring cups. So I teach the mother this much of atta if you take, it will become a 15 gram, this much of rice, raw rice. And when you cook a rice, it will become this much. And you can have this, like so much of amount of carbs will come. And as per the age of the child, we advise them so many carbs are required and only insulin is given as per the carbs. Remaining food, they have to take more of proteins, the vegetables and all that. We all know about that. We have got a urine ketones, bedside availability, and we do prescribe parents about this, and we tell them to monitor the ketones in the home when sugar causes more than 250. So coming to the case scenarios. So what I discussed in the first case, she was put on a mixture, which was usually practiced in the past. Sorry, I got a cough. So with that, like we were able to prolong her life with the insulin, but we were not giving her a comprehensive care. She was already into the complications of diabetes. With the newer management, and we have got a better managements like using a basal bolus regimen, using a carb counts and all that, we can have a better quality of treatment, better control of sugars and the quality of life, and we can try to avoid the complications, or we can prevent the occurrence in the earlier age. But for many of them, cost is an issue. And for many of that, in our country, many are uneducated. It will become very difficult for us to teach carb counts to the parents. So, but if you start doing it, many will understand. And if we have a group discussion, like with those who are educated and uneducated, like can combine together and make a group discussion, we can surely have a better control of all the diabetic kids in India. This is how we monitor their quarterly sugars, quarterly monitoring weight, height, BMI, BP, HbA1c, injection sites, and their SMR. This how would you do annually for screening of the complications and the other associated autoimmune conditions. Thank you. Hello.
Thank you. Hello, ma'am.
I did justice to the talk.
Yes, ma'am. It was a very informative talk. The session is open for question and answers. Ma'am, we have a question in the chat box.
Yes, ma'am. I'll just
transplant recipients need lifelong immunosuppressant therapy. Are glucocorticoids routinely added in these regimens?
Okay. So I have no idea about that, ma'am, because we haven't done any transplant. Like India also, it is occurring in the less, like not frequently done. Recently, in PG, I think SGPG, they have done it. They usually don't use glucocorticoid in that.
What is the incidence and management of SID? I think it's sudden.
Not SID is
that similar?
Steroid-induced diabetes, ma'am. Steroid-induced diabetes. Ma'am, I've seen like till now only 1 or 2 the steroid-induced diabetes, and inside to the child, even syndrome also. I don't know which came first, whether the nephrotic syndrome case or this. Yes.
Any role of stem cell transplantation on type 1 diabetes?
Yeah, the artificial, like we say, I just said, they can be using the whole pancreas or the islet cell, but because of the limited availability of these islet cells, they're trying to, and these stem cells are either grown in vivo or they are made to channelize so that they can produce only insulin. It can be still a better future. Stem cell, it will allow us to, like pancreas donors is very difficult. So stem cell transplantation can be a good option for type 1 diabetes. Maybe in the future we'll come to know the results.
Ma'am, there is one question from our side. Are there non-invasive glucose sensors are currently in use, ma'am?
No, ma'am. The same thing which we are using. We're not. I'm not aware about it.
Okay. Any more questions from the delegate side?
Madam, I have a question.
Yes. Yes, sir.
It's slightly different. Like, see, majority of the pharmacology people will not be practicing. Some of them do practice, yes. But then, what is the authentic source or resource to collect all the information about recent drugs and gadgets, especially the gadgets?
Sir, we have actually ISPAT guidelines. 2018 was the old one. Now, ISPAT 2022 may be released in a few days.
Okay, madam.
You can have the information on ISPAE website also. It's the Indian Society of Pediatric and Adolescent Endocrinology, or the ISPAD 2018 guidelines are freely available on the net. So we can download.
Okay, madam. Yes, thank you. Thank you, madam.
Any more questions from the delegate side? Thank you, Shaila madam, for sharing your experience and latest updates and giving us the importance of use of sulfonylureas in specific genetic mutations.
Yes.
Thank you very much, madam.
Thank you. Thank you, madam.
Thank you for joining us. Thank you. Yes. Now let us disperse for the lunch and we'll join back at 2:25 p.m.
Just I will take only just 5 minutes for regarding the insulin, and then shift to what we have, and then the newer tablets.
Good afternoon, everyone. Dear delegates, please join us for the post-lunch session. We have a very much renowned speaker with us for the 5th session. The session will be interesting too, since it is on the newer potential targets in the management of diabetes mellitus. It is our great pleasure, honor and privilege to have Dr. S.K. Srivatsa sir with us. Many of us have read the sir's books in pharmacology. I am fortunate to introduce sir today. Sir is an MBBS and MD pharmacology from King George Medical University, Lucknow. Sir has teaching experience of 34 years. Sir has published many research papers and articles and authored 8 books in pharmacology, including pharmacology for MBBS. And one of the recent one was based on CBME. Sir has been MCI assessor and coordinator. Sir was an ex-member, Signal Review Panel, PVPI, IPC Ghaziabad, and a member of various academic and scientific society of India. Sir is an awardee of CL Malhotra's Research Prize in 1997 by APPI and Fellowship of International Medical Science Academy in 2013. Dr. Sachendra K. Srivatsa is presently working as a professor and head Department of Pharmacology, Vedanta Institute of Medical Sciences, Maharashtra. We are honored and fortunate to have you, sir, with us. Now I hand over the platform to you to begin the session with.
Good afternoon, everyone. I think you can hear. Can you hear?
Yes, sir,
Yes.
we can hear you.
Okay. Can you see the slides? Hello.
We can see a screen, sir. Yes, sir.
Can you see?
Yes, sir, we can see the screen.
Okay. So, a very good afternoon, everyone. It is post-lunch session that is visible. So now target this topic given is newer potential targets in the.
Please put on to
Hello.
slideshow, sir.
Hello.
Can you please put the slideshow, sir?
Okay, sure. I think you can see now.
Yes, sir. Yes, we can see the full screen.
Okay. So when target given was, then I was thinking that already we have so many drugs available. So anyway, that is also required. So many things have to be done. So I think I will just in 5 minutes, I will just revise whatever is the treatment. Everyone is aware about that. The treatment of diabetes is treatment of diabetes itself, as well as prevention and treatment of complications, microvascular, macrovascular, and type 1 is mainly managed by insulin and type 2 by other drugs also. And before I proceed, little about the insulin. because there is also various problems in the insulin administration, injection, patient compliance. So all the various routes of insulin administration are also under trial already. I'm sorry, oral. One of the compound oral is ORMD0801 in poorly controlled patients. It has achieved a significant reduction in hemoglobin A1C without an increase in the frequency of hypoglycemia or weight. And it can be the first commercial oral insulin preparation and currently entered in phase 3 trial. So may be available later on. Inhaled insulin is also under trial, and that is aim is to overcome the drawbacks of Exubera, which was not very successful. And another inhaled insulin was Afrezza, which is approved but not very popular, not accepted. Also because of some adverse effect like cough and throat irritation, and it cannot be used in the smokers. And transdermal, the many preparations are under trial. I just have a list of that: microneedle, transdermal patches, sonophoresis, iontophoresis. All these various modalities have been tried. They are under trial for that. And not only that, insulin combination with other drugs, other peptides, like two of these have been approved. That is D-glutate with liraglutide, and another one is insulin glargine with lixisenatide. These are approved to be used for the human being. And there is also to replace the subcutaneous, this continuous SC infusion, insulin infusion is not very commonly employed, also costly, and have problems in the use. And therefore, there is a need to other pumps like patch pumps are smaller, which are introduced, which are under trial. They are small, flexible, discrete, without tubing, cheaper, making them more attractive than CSIS system. So there are some pumps which are under trial. So I don't want to go into detail of that. Then whatever drugs we have. So my question, do we have enough? And there is also need to have more measures to be taken, whatever we have to properly utilize for a rational treatment. And also newer agents, new targets are always there, but do we utilize the older one in a proper way? So everyone is aware. I'm just revising that in just 2 minutes. Already the drugs which are commonly used, that is KATP channel blockers, sulfonylureas, maglitinides, diphenyl, alanine derivatives, insulin sensitizers, biguanides, thiazolidinediones, and alpha glucosidase inhibitors. And apart from that, in last 10 years or more, we have many other newer agents which are mainly used as add-on therapy, like amylin analog, tramlintide is the example, glucagon-like peptide, exenatide, liraglutide, and many more have been introduced. DPP-4 inhibitors, gliptins, like there are many agents are there, sitagliptin, vildagliptin, all that. And then sodium glucose co-transport 2 inhibitors, phenagliflozin-like drugs. So we have also many other drugs which are already approved, and many agents of in class 1 class has been approved to be used for the management of, mainly for the type 2 diabetes, together with other agents. So we have enough, and there is also another area that whatever we have, that should properly be utilized, because there are so many other factors which are important, because newer target does not solve the problem. It is also required to have whatever we have should properly be utilized. And in search of that new targets, often the older drugs have been tried for because those which are already available, like bromocriptine, it was tried and approved in US also. It increases hepatic glucose production, increases glucose tolerance and insulin sensitivity. It can be used as adjuvant, can also be used together with that or in combination with metformin or sulfur. Then these are the drugs, FATP5 inhibitors, which enhances the uptake of long chain and very long chain fatty acid into cells, mainly patient who are
You are not audible, sir. I think there is some network glitch. Sir, am I audible to you, sir? I think there is some network glitch from sir's side. We'll wait for a minute. Sir, you're on mute, sir.
just a minute. Now, can you hear?
Yes, sir. We can
Hello.
hear. Yes, sir. We can hear you now.
Hello. Okay. 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 Now we'll proceed. Sorry for interruption.
No problem.
This is a remote area, so power cut is very common.
Yes, sir. No problem.
So next, these are some old drugs have been utilized as mainly as adjuvant, and now coming to other drugs. The new targets which have been tried. Hello.
Sorry for interruption, sir. Can you please?
Can you hear now?
Yes, sir. Can you please share your slides, sir?
Hello.
Again, our own
Okay. Okay.
present together our own donor cells means that there is a graft failure. Got it?
It's okay.
Yes.
Hello.
They're doing bone marrow transplant.
Can you see?
What is bone marrow?
Hello.
Just a second, sir.
You can see and hear also. Okay. Sorry
No,
for the inconvenience.
still can't see the slides.
Okay. Now then the new targets, the drugs have been developed having in mind that the drug. Hello.
The
Hello?
slides are yet to
Hello.
be. Sir,
Hello?
the slides are not seen, sir.
Okay, I will just. Okay.
Screen share, madam.
Now can you see? Hello.
It's yet not visible, sir.
Now can you see?
No, sir. No, sir.
Can you see?
No, sir. No, we cannot see, sir. Stop sharing and reshare, sir. Please close the PPT and open again, sir. We can see the slides, sir. The slides are visible, sir. Please unmute yourself, sir. So we cannot hear you, but the slides are visible, sir.
Now it's okay?
Yes, sir. We can hear you and slides are also visible, sir.
Okay, I'm sorry, it is a remote area, power cut is very common, so kindly bear with me. Okay.
That's okay, sir. Please proceed.
Now coming with the newer targets. So aim was the whatever various compounds have been synthesized with additional mechanism. So now there was GLP-1 receptor and GIP receptor dual agonist. So they are dual agonists have shown significant reduction of hyperglycemia and weight loss compared to GLP-1 or agonist. And one of the agent is recently been approved. Peptide, it was recently approved for the type 2 diabetes. By USA, just last month it was approved to be used. So it is a GLP-1 receptor and GIP receptor dual agonist. And it is just a once a week subcutaneous injection, and it achieves the superior hemoglobin A1C and weight reduction. It has been found that weight reduction was substantial and sustained compared to semaglutide or other agents in adults with type 2 diabetes. So that is shown in the phase 3 trial, and then drug was approved. It is a recently approved drug and maybe a very promising drug in future. Another target was other same group, GLP-1 receptor and GIP receptor dual agonists are also under. One is in the phase 2 trial, daily SC injection, and another one is in the stage. So others are also doing this trial. And just to inform that there are more than 100 drugs under clinical trial right now. So I have selected few one which are already approved or which are in under trial in the phase 2 or phase 1. Then glucagon receptor blockers have been developed. One of the agent is RVT1502, a novel oral glucagon receptor antagonist in type 2 diabetes. There is another one, antisense oligonucleotide. It is in the phase 2, and one more is in the phase 2. It is the
Excuse me, sir. Sorry to interrupt. Voice is not clear. Can you please put off your video and just speak with the slides, sir? Hello?
Already ಇದ್ದಾರೆ.
Hello?
ಅವಾಗ ಜಾಯ್ನ್ ಆಗಿದ್ರಲ್ಲ ಮೇಡಮ್ 1:30 ಜಾಯ್ನ್ ಆಗಿದ್ರು.
Sorry for the disturbance. Excuse me, sir. Can you hear me, sir? Hello?
Yes.
Sir, can you hear me, sir?
Yes.
But your voice is not clear, sir.
Yes. Okay.
You can put your video off and talk, sir, so that it will be a good network. There will be no network issue.
Is that okay? Yes. Can you hear? Can you hear now? Can you see and hear?
Hare Ram, Hare Ram, Hare Krishna.
Can you hear now? Hello. 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 Can you hear?
Yes, sir, we can hear you.
Okay. See. Can you see slide also?
Yeah, we can see your slide, sir.
Okay. Okay. So next was the GLP-1 and GCGR dual agonist, and one compound is under phase 2 trial that already I had talked. And then they have tried the triple agonist, GLP-1R, GCGR, and GIPR triple agonist. Based on the finding that after gastric bypass surgery, it was noted that endogenous GLP-1, GIP, and glucagon secretion was increased. It was hypothesized that these incretins synergistic metabolic action could lead to weight reduction and synergistic incretin effect. And for that, then this compound is currently in phase 1 clinical trial as a weekly subcutaneous triple agonist. And another one of the same group is under trial for the obesity mainly, and particularly associated with the diabetes. So that is another, they have this triple mechanism, triple agonist. Next one is that already we know that SGLT2 inhibitors are already in use, and many agents have been introduced in last 10 years. So attempt was made to have a SGLT1 inhibitor combined with that. So compounds have been synthesized, and based on that, combined SGLT1 and SGLT2 inhibition resulted in significant postprandial glucose reduction, elevation of endogenous GLP-1 and urinary glucose excretion. Sotagliflozin is one first dual SGLT1 and SGLT2 inhibitor. It has a 20-fold higher selectivity for SGLT2 than SGLT1. It is as effective as dapagliflozin and canagliflozin in inhibiting the SGLT2, but 10-fold more potent than them in inhibiting SGLT1. So it is under clinical trial phase 2 and 3, and that trial have shown improved glycemic control, reduced postprandial glucose, reduced insulin requirements, appetite suppression, weight loss in patient of type 1 and both type 1 and 2. And from the same class, lycogliflozin is another such agent under trial. So under trial, after successful trial, may be approved for the use, clinical use. Okay. Another one is that we have already we have PPAR alpha agonist like fibrates are PPAR alpha agonist, mainly used as hypolipidemic drug. We have PPAR gamma agonist, which are used for diabetes as mainly insulin sensitizer. So now attempt is there to have triple agonist of all these, alpha, gamma, and delta also. Alpha is mainly in the liver, muscle, heart. Gamma is adipose tissue and vascular endothelial cells. And delta is widespread, whole body distribution, regulates energy expenditure. So attempt was made to have these combination. So one drug was seroglitazar, which is a dual agonist of PPR alpha and delta. And I'm sorry, alpha and this is a mistake. There is a gamma. Okay, so that was already approved. It belongs to glitazars. It is a dual peroxide proliferator activated receptor agonist. That is alpha and gamma. This is not delta, it is gamma. It has higher affinity for PPR alpha and all than gamma. So that mainly affects the lipid level, and fibrates are acting by this mechanism, and gamma, the glutazones, are used by this mechanism, act by these mechanisms. So this drug reduces level of triglycerides, LDL cholesterol, increases HDL cholesterol, and reduces blood glucose apart from the hemoglobin A1C level. It is also insulin sensitizer, so it acts by dual mechanism. That is the PPR alpha and gamma. It has recently been approved in India for the treatment of diabetic dyslipidemia or hypertriglyceridemia in patients with type 2 diabetes not controlled with statin alone. So that is combined the PPR alpha and gamma. And next is that they have combined all the PPR alpha, gamma, and delta. That is triple agonist of PPAR, and the drug is under it is phase 3 trial, undergoing phase 3 trial, randomized double blind, and as well as sitagliptin control trials in patients with type 2 diabetes with insufficient glycemic control despite diet and exercise. It is orally administered and approved in China recently for use as an adjunct to diet and exercise to improve glycemic control in adult patients with type 2 diabetes. It is also in phase 2 trial in China for treatment of non-alcoholic, that is another indication for the same drug for non-alcoholic steatohepatitis. So that is a triple agonist having a PPR alpha, delta, and gamma. There are two other compounds are also triple agonists. They are under clinical trial for the same. So that is another combine the all these actions in one drug. Already it is approved in China. Let's say a new class of drug is imaglamine. It's glymin's. It is the first member of this class. It is a novel oral anti-diabetic drug. It is approved for use in Japan in June 2021. It has a unique mechanism of action, inhibits the oxidative phosphorylation of protein, phosphorylation protein kinase B in the mitochondria of aerobic cells, and thus it has many actions. It increases insulin sensitivity, increases the beta cell mass, improves the glucose-induced insulin secretion from beta cells, reduces the hepatic gluconeogenesis, protects against beta cell death because of by reducing the oxidative stress. And not only that, it also has cardiovascular, improves the cardiovascular function. It reduces the left ventricular end diastolic pressure and increased LV, left ventricular tissue perfusion, that is potentially cardioprotective in addition to its anti-diabetic property. So that is additional property of this class of drug. So it is approved in Japan only, and based on its, so it can be a very effective drug as monotherapy and also as an adjunctive treatment because it lacks the major adverse effects and has cardioprotection. May play a crucial role in the treatment of type 2 diabetes. So one compound is approved in Japan.
Excuse me, sir.
Yes, please.
Sir, audio is not clear, sir.
Now, can you hear?
Yes, sir, we can hear you.
This is the mechanism of that just a diagrammatic presentation that imine glycine, which is approved. It has many actions: increases insulin sensitivity, suppresses gluconeogenesis, improve beta cell function, and also reduction in oxidative stress. It is recently approved in Japan for the type 2 diabetes. Then another target is free fatty acid GPR40. Based on that, free fatty acids play key role in the regulation of metabolic homeostasis, and FFAs activate specific G protein coupled receptor in pancreatic beta cells, immune cells, adipose, and intestine. This receptor is primarily expressed in pancreatic cells and is activated by medium chain and long chain free fatty acids. FFA receptor 1 has been shown to augment glucose dependent insulin secretion from pancreatic cells and is widely studied drug discovery target for the treatment of type 2 diabetes and other metabolic diseases. And one such agonist, TAC875, in phase 3 trial has shown to improve glycemic control in type 2 diabetic and other beneficial effects. But trial was terminated due to signs of hepatotoxicity of the drug, a compound which was under trial. However, this FFAR1 agonist provide an attractive alternative in the discovery of new anti-diabetic drugs. And these are the other compounds of the same group, that FFAR1 agonist, which are under trial in phase 1 trial, AMG 837, T11187, and LY 29222470. They are under phase 1 trial. So maybe that if they don't have such toxicity, will be promising agent later on. So that is another very good target to develop a newer anti-diabetic drug. Next is one agent is ipalristat. It is already approved and available. It inhibits the aldose reductase and significantly reduces intracellular sorbitol accumulation, which has been implicated in the pathogenesis of late onset diabetic complex neuropathy. So it is for the neuropathy and also for retino and nephropathy, that is the for that purpose, and approved in Japan for treatment of diabetic neuropathy and retinopathy. So it is not for the diabetes, but for the for treatment of diabetic complications. Then as we are aware that 11 beta hydroxysteroid dehydrogenase that they inhibit the conversion of cortisone to hydrocortisone. So that inhibition offers a new potential approach to control glucose and cardiovascular risk factors in type 2 diabetes. This is one compound which is under trial and that improves the hyperglycemia in patient with type 2 diabetes inadequately controlled by metformin monotherapy. Addition of once daily dose was well tolerated, resulted in significant improvements in hemoglobin A1C, fasting blood glucose, decreased the body weight and improved cholesterol and triglyceride in patient with hyperlipidemia at baseline. Further long-term control studies are warranted. And there is another compound, 096. It is a daily oral dose that produces substantial inhibition of liver 11 beta HSD1 and 11 beta HSD1 in subcutaneous adipose tissue. Such treatment is also generally well tolerated, but it may have various other actions also. And therefore, the clinical usefulness has yet to be determined how useful this will be, particularly when we compare the already so many drugs are available. So overall, how much this will be effective has yet to be investigated. Then another is group is sirtuins. Sirtuins are a family of NAD-dependent deacetylases, which modulate a range of metabolic processes together with age-related conditions, including obesity and type 2 diabetes. SIRT1 and S6 have been found to have a role in maintaining insulin sensitivity. In the pancreatic beta cells, overexpression of SIRT1 was noted to augment insulin secretion, leading to improved glucose tolerability and enhanced insulin sensitivity. And metformin also additionally directly activates SIRT1 among various other metabolic effects. And based on this idea led to idea of potential usefulness of SIRT1 activating agents in the treatment of type 2 diabetes. So based on this finding, and one of the agent resveratrol that is present in grapes has been shown to activate SIRT1. And it has been shown to, the studies on resveratrol has shown that positive effect on glucose homeostasis in rodents. And several studies have reported improvement in insulin sensitivity, glycemic control, and other metabolic parameters in patients with type 2 diabetes. However, the available research till date was insufficient for evaluation of safety and potency of resveratrol therapy for treating. So there is need of clinically safe and effective SIRT activator for treating type 2 that has yet to be found. So that provides a base to further develop these compounds to be useful for type 2 diabetes. And now cutting it short, there are many other targets. So I've just made in the form of a table. This is the drug which is used, DS8500. It is a GPR11 agonist. It stimulates the insulin release. It is under phase 2 trial. And melatonin has also been under evaluation in phase 1 trial. Melatonin receptor agonist are, it is that improves the insulin sensitivity and suppresses the gluconeogenesis. So phase 1 trial. One more is that protein tyrosine phosphatase 1B inhibitor. One compound is KQ791 that causes the protection of insulin receptor from inactivation, and this is also in phase 1 trial. And this is a human provilate peptide, and one drug is this BTI410. It increases beta cell mass, and it is entered in the phase 2 trial now. And one more drug is fibroblast growth factor analog, pegbelfermin. It promotes the insulin dependent glucose uptake, and it is under phase 2 trial. And one more compound is 0304 is AMP analog. It causes AMPK activation and produces insulin sensitizing effect, again in the phase 2 trial. And last compound is TTP399. It is glucose kinase activator. It promotes the conversion of glucose to glucose 6-phosphate under phase 2 trial. So there are many other drugs which are under evaluation in different phases of clinical trial, and some of them are under preclinical stage. So more than 100 compounds at present are undergoing trial, utilizing the new target, and sometimes more than one mechanism. They have been developed to act by the more than one mechanism, and only few of them have been approved till now. So these are newer targets, but there is need to utilize whatever drugs already we have. We have last 10 years we have enough drugs introduced, but there is a proper management of utilizing the old drugs is also need of the hour, apart from the newer drugs, new delivery systems. So that is what is required in recently. So I think that finishes the. I have not included all the drugs, but which are approved, and some of them which are under trial.
Thank you, sir. Now the session is open for the question and answers. I request the delegates to ask the questions.
Delegates, please unmute yourself and ask the questions if any. The session is open for question and answers. Delegates, if any questions, please mention in the chat box or please unmute yourself and answer the question. Ask the questions.
I think there are no questions. Thank you, sir, for sharing the vast experience and giving us the latest discovery and development in diabetes mellitus therapeutic area. I'm sure this will be a great help for us, practitioners and the postgraduates. Thank you, sir.
Thank you very much. And I'm sorry for the interruptions in that because of the power cut here in this area. So I'm very sorry for that. Okay.
That is okay, sir. Thank you for joining us.
Thank
sir.
you. Thank you. Thank you.
Thank you so much.
Okay.
Excuse me, sir.
Hello.
There is a question, sir.
Yes, yes, please, please.
How do PPAR agonists help to reduce glucose?
PPR agonist.
PPAR.
PPR gamma agonists are already in use, like glitazones, pioglitazone. They are mainly insulin sensitizers. So they are already in use. And PPR alpha agonists are also in use. That are fibrates, which are used for as lipid lowering agent. PPR gamma, that is glitazones, pioglitazone like drugs, they are also in use. So attempt has been made to combine more than one mechanism, alpha and gamma, and also triple agonists, alpha, gamma, and delta. So that is what new agents have been developed and which are under trial. So pioglitazone is well known. How does it produce the anti-diabetic effect? It is very well, this drug is used since long. Rosiglitazone is banned in India, but it is revoked. Ban was revoked in US because they have not found any serious adverse effect over 10 years. So still in our country it is banned. Pioglitazone is that drug which acts through PPAR. Okay.
Sir, there is one more question, sir. Side effects of tirzepatide.
Which one?
Tirzepatide, sir. Side effects of tirzepatide.
Tirzepatide, which drug? Can you spell?
TIRZEPATID, tirzepatide.
Tirzepatide, which was recently approved.
Yes, sir. Side effects of that.
Not very significant side effect.
Okay.
Therefore it has been approved. Mild side effects are there. Therefore it has been approved. Recently approved. Just last month it has been approved by US.
Okay. So there is one more question, sir, regarding the update of vaccine targets for diabetes mellitus.
For vaccine target?
Yes, sir. Is there any vaccine target for diabetes mellitus?
At least I have not come across any such.
Okay.
Maybe I will search. If you are asking the question, then I will try to find out.
Okay, so there is one more question. GAD molecule.
Which one?
GAD molecule.
Yes.
It's the answer for vaccine. Okay. So they have mentioned the answer for vaccine, sir, by Dr.
Okay.
Rohan Srivastava.
Okay, nice.
Thank you so much, sir, for joining, sir. Thank you, Rohan, for giving me the link of Dr. S.K. Srivastava, sir. It's our honor and privilege to have you, sir. We will begin with the next session.
We'll begin with the next session, Future of Diabetes. Are we near for a queue by Dr. Nikit Roy? I hope Nikit Roy, sir, is online.
Yes, I am here. Thank you.
Yes, sir. Sir, welcome. I welcome you, sir.
Yes.
Dr. Nikit Rai, sir. I welcome you, sir. Dr. Nikit Rai, MD Pharmacology from Mahatma Gandhi Memorial Medical College. Sir has teaching experience of 9 years. He was a co-investigator for Lambda Therapeutic for phase 1 studies. Various publications in national and international journals. Presently, sir is working as an associate professor in the Department of Pharmacology, Maulana Azad Medical College, Delhi. Sir, we are privileged to have you with us. Now I hand over the platform to you to begin the session, sir.
Thank you very much. I am sharing my slide now.
Participants, please unmute yourself. Or mute yourself. Please mute yourself. We can see your slides, sir.
Are you able to hear me?
Yes, sir. We can hear you and slides are visible, sir.
Is my video working?
No, sir.
Okay, just a minute. Okay, hello everyone. I think video is not working. Maybe it will work later on. But more importantly, the audio is working and slides are visible. That is very good. Am I audible?
Yes, sir. You're audible, sir.
Okay, so first of all, I would like to say hi to all of you and a very hot good afternoon to all of you from Delhi. And I am very thankful to this organizing committee of GIMS GADAG, Karnataka for giving me an opportunity to speak along with eminent speaker around the world on this topic of diabetic update, which is very important in present scenario. And the topic given to me is future of diabetes care. And the question is, are we near cure? So because it is not a core pharmacology topic, it will not be boring. That is also a good thing. So let's see what is there in the future of diabetes. So I will present my talk on this outline that I will show you some slides on history, which is a single slide, and then global impact of disease and the global market to build on some important facts that will help us to understand the future and why we are asking this question, are we near the cure? I request organizing team to let me know any point of time if there is any technical glitch comes as I am starting my talk. So then basically in future we will talk about the future of treatment of diabetes type 1, type 2, and also a very important thing that is blood sugar monitoring, because nowadays patients are receiving many pricks to find out their blood glucose level, and then the next and the last will be the what next. So if we look back into the history, we can surely say that we are aware of this disease since thousands of years. In ancient Indian literature, in ancient Egypt literature, there is quite mention of this disease where our great scientist Sruta has found out the association of sweet tasting substance with polyuria, that is diabetes mellitus. And the word diabetes came because there is a symptom of polyuria, that is a continuous flow, like an open tap. So Eritas from Cappadocia, they coined this term diabetes. The point is that after thousands of years, after knowing the disease, still we are asking this question that are we near cure is really very unfortunate. Because the impact of disease is severe. The data which I got is that since 1980, the patients per 108 million, which rises to 4 times in 2014 and continuously rising, currently around 460 million patients of diabetes. And it is estimated that by the end of 2045, the impact will be like 700 million of patient will be there with diabetes. So that much of impact this disease is having in our life, and the disease which we know since thousands of years. And in next 10 years, it is expected that the compound annual growth rate of this market will be rise by 10.4% from around $1 billion to $4 billion. That is 4 times jump is expected. So, and from where this money is coming? This money is eventually coming from the pocket of the patient. So patients are still suffering. They are still suffering financially. They are still suffering emotionally. They are still suffering physically, mentally. And we are asking this question that are being cured. So this is not a good sign. But let's see. At least we are asking this question. That is a good sign. So what will be the future? Future is only mainly focus on these two type of diabetes, type 1 and type 2, where 95% patients are of type 2 diabetes and 5% patients are of type 1 diabetes. But as Dr. Shaila told in her presentation that in pediatric population, it is more than 90% type 1 diabetes. And all the patients need blood sugar level monitoring. So what kind of research, what kind of work is going on in these fields to find the cure or treatment or better treatment for these two type of diabetes mellitus, or how will we protect the patients from continuous pricking or the invasive methods of blood sugar level monitoring. So if we see what is going on in type 1 diabetes mellitus, so the biggest hope today is cell therapy. And then immunotherapy and artificial pancreas are again the future of type 1 diabetes mellitus care. So let's see one by one. As far as cell therapy is concerned, as I said, it is a biggest hope. And what actually cell therapy is? It is a transplantation of beta cells of islets of Langerhans from a non-diabetic or normal patient to the diabetic patient. Simple, right? So because we know that this beta cells, or we can say insulin producing cells, are getting targeted by the autoimmunity of the patient, which leads to type 1 diabetes mellitus. So if you replace it with the normal functioning beta cell, it might get some cure, and it might take us out from this continuous problem of taking insulin and other drugs. So, and the challenges here, in 1984, actually, for the first time, Gray et al. Published a paper on successful extraction of beta cells, but the yield was less than 30%. 4 years later, Ricordi et al. From DRI, USA, they published paper in 1988 with successful extraction of beta cells with yield more than 90%. And then it actually opened up the doors for this research. But there are still a lot of challenges as far as cell therapy is concerned. There are 3 challenges. One is the researchers are still struggling with the site, where to implant. Second is sustainability. Once implanted, how to protect these beta cells from the immunity, the adaptive immunity of the patient. And third thing, which Dr. Shaila very well mentioned in her presentation, that supply. The donors are limited and the demand is high. So as far as site is concerned, earlier the conventional site was liver, but due to the limited success, now many researchers are working on finding different sites, in which Momentum was one of the sites which was found by Diabetes Research Institute researchers, and they already got approval from FDA to proceed their clinical trial, which is they are conducting phase 1, phase 2 clinical trial right now to check whether Momentum is a better site than liver or not. And another site they are working on in collaboration with Bascom Farmer Institute also got approval from FDA to conduct phase 1, phase 2 trial, where anterior chamber of the eye may be the potential site in future beta cell transplantation. As far as sustainability is concerned, so to protect this transplanted cell, it is very important to protect them from the adaptive immunity of the patient. So this Diabetes Research Institute Miller Medical College, Miami, USA, they are working on bioengineered mini pancreas, where these insulin producing cells after transplant are encapsulated with a protective layer to protect them from getting damaged by the immune cells. And they already published one successful result in 2016 where the patient is now insulin free since 2016 after he received this bioengineered mini pancreas, that too implanted in Momentum, the same study that contained the site study also. Another company, Biosite from USA, in collaboration with a non-profit organization, JDRF, they have designed a device which is a pouch-like device in which the beta cells are protected and the necessary supply of nutrients, hormones is there, and it is implanted and preventing the immune cells from directly contacting the implanted cells. So they may thrive and function without provoking an immune response or being destroyed. Another collaboration of Biosite with CRISPR, they made a device, VCTX210, which is an allogenic gene-edited immune evasive stem cell derived therapy for treatment of type 1 diabetes. All these are in pipeline. These are not available in market, but the work is going on. Then another German company, Evotec, they are working on a stem cell based beta cell replacement therapy, which is right now in preclinical development phase. Then Procyon Technology in collaboration with Novo Nordisk, they are working in again an encapsulated device like oxygen enabled implantable cell encapsulation device, which will protect the stem cell derived insulin secreting cells. So the device encapsulation device is the expertise of Procyon, and stem cell derived insulin cell production is the expertise of Novo Nordisk. So they collaborate and trying to produce a device that will protect the transplanted immune cells, beta cells, from the adaptive immunity. So this first picture is the DRI project where they are using Momentum as the site where they use thrombin to make a combination of beta cells with the glue-like solution, which will then overlapped by the Momentum fold to protect it from the immune cells. And these VC2, VC1 and VCTX210 are Biosite products where they are making a pouch containing beta cells, and the supply of nutrient is sufficient, but the protective layer is there which will protect them from the immune cells. So this is some research going on in the field of maintaining the sustainability of transplanted beta cells. But challenges are that they are still in initial stage of development and far from the market. And obviously affordability will be an issue as the cost could be steep, but at least some cure will be provided to the patients. There is some hope. The third challenge was the supply, that the donor are limited. So to abolish the dependency of patient on the donor. So currently a lot of research is going on in this field where islet cells used for transplantation come from means researchers are developing a lot of ways to create a reliable and plentiful supply of oxygen producing cells, or even regenerating a patient's own pancreatic cells. So to avoid the dependency on donor, what researchers are doing, they are using the exocrine part of pancreas of the patient and making it work like endocrine gland. Like some 98% of the pancreas is exocrine, only 2% is endocrine. If 2% is not working, take some cells from the exocrine pancreas and make them function as beta cells. This is what the future of cell therapy is. In this regard, a paper also published by Dagmar Klein et al. In 2015, where they used bone morphogenic protein 7 to induce adult human pancreatic exocrine to endocrine conversion. Another paper published in Nature 2017, where this engineering an endocrine new pancreas by repopulation of decellularized rat pancreas with islet of recurrence by H. Napierella et al. So what they are doing is, here you can see in the picture that pancreas is decellularized by perfusion with alkaline detergent. So first it gets decellularized. Only the matrix is left with the vascular and tectular protein network, and it will become the non-immunogenic, that is non-reacting to the immune cell. And then this matrix is then repopulated by by infusion of islets and endothelial cell to generate a function implantable organ. So maybe in future, the patient will not dependent on the donor to provide them beta cell. Rather, the researcher will, or the research will enable them to convert exocrine cells into endocrine, and they start producing insulin. So all these challenges, if overcome in next few decades, there will be a cure to diabetes possible in the form of cell therapy. Second is immunotherapy. A lot of work is going on in this field also, because diabetes is an autoimmune disease and directly caused by immune system. So immunotherapies have started being investigated as an approach to treat a number of different autoimmune diseases, including type 1 diabetes. The concept here is to protect beta cells from the immune response of the patient. If it is successful by giving immunotherapy, which is protecting the cell from the immune cells of the patient, the progression of disease can be altered, and maybe someday there is a research going on which says immunotherapy might prevent the development of type 1 diabetes as well. But for that, it is very important to detect the probability of having type 1 diabetes in the patient prior to the symptom appears. And most of the type 1 diabetes occurs in early age. So at very soon, like after birth in newborns, if there's some technology developed that can detect the probability of getting diabetes type 1, and at that time, if we give immunotherapy, that the type 1 diabetes can be prevented. So that also is going on, that research is also going on. Some microchips are being made in Australia. We'll discuss about that, which can actually detect the probability of type 1 diabetes in newborn. So in future, it may be seen. Right now, as far as immune therapy is concerned, some companies are working on it, like Insight Biotech. They are conducting their phase 1 trial. They're very enthusiastic project of unique Hemotope technology platform, and they already concluded that there was no major health problem in phase 1 trial, and it met its primary endpoint. In addition, they claim that the drug showed sign of clinical benefits such as lowering the number of autoimmune cells in the patient's blood. Another company, Provention Bio, is working on antibody immunotherapy, which they claim to be delayed the emergence of type 1 diabetes around 2 years, which will give you time to, find out some another treatment modalities to treat the patient. French biotech, they are working on preclinical vaccines. Somebody asked this question in previous presentation, where what are the targets for vaccines? The answer was GAD molecules for the target, and not much is known about it right now. They are in preclinical phase, but these companies are working on these vaccines, which could stop the progression of type 1 diabetes in recently diagnosed patients. Then another company, Therapeutic, they are working on a combination therapy of their product AG019 with teplizumab, which is a combination therapy that stimulates. Teplizumab is anti-CD3 molecule, which was discussed in previous presentation of Dr. Shaila. So this combination therapy is proved to stimulate regulatory T cell, and these cells will instruct the immune system not to attack insulin producing cells. So anyhow, the immunotherapy will protect the functional beta cell from the natural immunity of the patient. The third domain in which the research is going on is artificial pancreas. This topic was also touched by Dr. Shaila in her presentation, and as she correctly said, that these are nothing but the modified insulin pump, or you can say the future insulin pump will be known as artificial pancreas, because the currently available insulin pump are smart but not smart enough, because they are still requiring work from user. They are user dependent, and we want the user to get free of this headache of maintaining their insulin pump of the devices, because so much of data is generated from these devices, which has to be analyzed by the user and then act accordingly. So in future, there will be artificial pancreas or automated pancreas, which will work as good as the physiological pancreas works. But there are three main challenges to overcome. One is it needs a faster, better, and smarter insulin. Second, multi-hormone system is required. And third is intelligent algorithm is required, which we will discuss one by one. So as in our second presentation on novel insulin, Dr. Harsha from Novo Nordisk does this concept of fast insulin kiosk. So many companies are working for making insulin fast, and Novo Nordisk made first of a new generation of insulin that acts significantly faster than conventional insulin. But as far as automated or artificial pancreas are concerned, it is not yet fast enough because meal absorbs faster than the insulin, and we need the insulin in automated pancreas or artificial pancreas, which will act hand in hand with the glucose absorption. Another company, Therapeutic, is working on making insulin highly concentrated, because more concentrated insulin will be, the smaller will be the size of the device. But the problem with concentrated insulin is that the absorption is slow. So they are working on making highly concentrated insulin that are also fast acting. So it is in phase 3 trial, maybe in future a better, faster and concentrated insulin will be available for automatic pancreas. A French company, Lion, is working on a shielding technology which will protect these insulin molecules from other molecules. So there will be less interaction, and hence insulin will arrive faster to the bloodstream. Again, all these companies are making insulin fast. Okay, and as fast insulin will be there, fast acting insulin will be there, it will overcome the first challenge of making artificial pancreas. Second is multi-hormone system. So this was like Dr. Shaila said, dual chamber pump, which contains more than one hormone in it. Because insulin is not only responsible for maintaining blood glucose, but amylin and glucagon are also responsible, as we all know. And amylin is actually helping insulin to work better. Like amylin, on the one hand, decreases the appetite, it reduces the absorption of the meal, and it also reduces the secretion of glucagon. So its overall action of amylin is to give time for insulin to act by slowing down the absorption of glucose from the GI. Glucagon, on the other hand, will protect the patient from hypoglycemia. So we need now artificial pancreas or the insulin pump that will be modified in future in a way that it will be pre-filled by all these hormones, and it will work as physiological as the normal pancreas work without depending on the users. But the challenge here is amylin, which is already available in injectable form by the name pramlintide. It is not stable in liquid form. So there are some groups like Heather's group at McGill University and Adosia Biotech. They are making these combination of amylin and insulin stable in liquid form. Similarly, glucagon is not stable in liquid form. It is available in powder form. So the company like Zealand Pharma, Xeris, Adosia, Arecor, they are working on making glucagon in a stable form in liquid form, so that all the three hormone can be pre-filled in that insulin pump, which is modified, and the most important and the last challenge is the intelligent algorithm. So right now the algorithm is there, but to make it more patient-centric, to reduce the inter and intra-individual variation, the algorithm should be smart enough to connect all the dots. That user should not worrying about anything. Whatever artificial pancreas must be totally user-free, and it should detect the demand of the insulin or glucagon depending on the situation. So the first step towards a fully automated system will be simplifying the calculation of how much insulin is needed for a meal, because that calculation is to be done by the user. In previous presentation, we found out that there are different amount of glucose or carbohydrate produced by different food items. So by first we need to calculate it, and then it should be injected. So that should not be user dependent, and it should be done by the smart algorithm. Because if there is too little insulin, it will lead to the risk of severe long-term complication. And if there is too much of insulin, it will lead to the immediate So there is these communities, the DIY community in USA, their statement is that the algorithm can be more precise than person to all the person dependency should be abolished by overcome these three challenges and making a artificial pancreas. As I already discussed, the immunotherapy is not only important for cure, but if it is, if we are able to detect the type 1 diabetes before the symptoms appear, the immunotherapy could also prevent the development of type 1 diabetes. So in future, maybe we'll get the prevention methods for developing type 1 diabetes mellitus.
So presentation ಇರಲ್ಲ ಪ್ರಾಕ್ಟಿಕಲ್ ತಗೊಂಡು ಬಂದು
So I request the organizer to please mute the participants. Yes, thank you. So this is all about type 1 diabetes mellitus, their cell therapy, immunotherapy, and artificial pancreas, the future. In as far as type 2 diabetes mellitus is concerned, the future goal is mainly to produce stimulating drugs that is stimulate insulin production, which we already have seen in previous presentations. And the new thing is targeting the microbiome. As far as stimulating insulin production is concerned, Novo Nordisk in 2019 went ahead of other companies and they came up with this molecule semaglutide, which is orally available, the only first-in-class orally available GLP analog. In previous presentation, Dr. Sachendra Srivastava was told about hemoglobin, which is approved in Japan, and they are now seeking approval in US, Europe, and their clinical phase 3 trial is going on. The French company Poxel has made it, and as previous speaker already discussed about its mechanism of action, that it is working simultaneously on more than one organ, that is in pancreas as well as in liver and as well as in muscles. So this is in future pipeline. Then Swedish company Betagenon collaboration with Therapeutic Bio, they are working on one molecule 4304 and conducting phase 2 trial, and they are claiming that this drug is helpful in not only reducing the blood sugar but also reducing the blood pressure, which will be very helpful for the patients of diabetes, having hypertension, and those who are obese. Then a German company, Morphosis, in collaboration with Novartis, they are working on a monoclonal antibody that is bimagrumab and conducting phase 2 trial. And again, they are claiming that it is having multiple action, like they reduce fat, also reduce the appetite, and also maintain the restore the insulin secretion. So targeting multiple sites and use for more than one indication. So this is the future of some drugs which are in pipeline for type 2 diabetes mellitus. The more interesting is this. This is targeting the microbiome. So in 2017, some researchers from University of Amsterdam, they found out that the fecal transplantation from a lean donor to the obese diabetic patient actually leads to the short-term reduction in overcome the resistance of insulin resistance and short-term improvement in overcoming insulin resistance in obese type 2 diabetes mellitus patient, and same result they saw in 2021 in early onset type 1 diabetes mellitus patient. So this microbiome or fetal microbiome transplantation, that is FMT, is maybe helpful in future for treating diabetes type 2 mellitus and help reducing the pill burden of the type 2 diabetes mellitus patient. And in this lead, French company Valbiotis is conducting a phase 2-3 trial where they found promising result in treatment of early stage of type 2 diabetes mellitus by fecal transplant. So these two things, one is producing drug that will stimulate the insulin secretion, and interestingly the microbiome fecal transplantation, and it is done very easily that the capsule form this fecal microbiota transplant is given to the recipient, and they will again But the problem with this microbiota is it is short term, because they are concluded that in 3 months, because of the dietary pattern of the patient or the recipient, the condition, the microbiome environment will become the same as previous. So they are working on long-term improvement by fecal microbiota transplant. Then the third domain where we know that all the patients of diabetes, they need continuous blood sugar level monitoring, for which the invasive methods are available, but now many non-invasive methods are also available. So let's see what are there in the future for needle-free revolution. So this is one device made by German firm Diamontech, using an infrared laser to beam light to the skin of the finger to measure sugar level. So it is one of the non-invasive device which will be available in market in future. And one device, Eversense, made by US-based company Sensionic. It is a subcutaneous implant that continuously monitor blood sugar level. It is also under research. Then United States and Israel company Integrity Applications, they made this glucotrack, which can monitor blood sugar level through a combination of ultrasonic, electromagnetic, and thermal waves. Another non-invasive device for blood glucose monitoring. Then this is GlucoVice, a product of Medivice, which use radio wave to detect the glucose level. So there is pain-free sensor, which is this is to be held in between the thumb and index finger, and then it will get the readings in application, mobile application. Then University of Bath, England, they have developed this graphene patch, which is a device that can measure glucose levels without piercing the skin. It is under pipeline again. This is an already in market Abbot's Freestyle Lifer, an inch-wide patch that can be worn for up to 2 weeks, and that requires a continuous subcutaneous needle prick to install the device. But better devices than this are already in pipeline, which will come in the market soon. Then this tiny device produced by Dutch firm Noviosense, which can be placed under the eyelid, and it will detect the glucose from the tears. But this road to non-invasive device is not very easy, because 2014 Google has launched its glucose measuring contact lens, which was then dismissed because of some technically infeasible thing 4 years later. So it was a dream project of Google to make this glucose measuring contact lens with having sensor and chip and antenna and soft contact lens, but it failed after 4 years of launch. So the road to success of these non-invasive device is also very difficult. Then comes what will be the next thing, which I already discussed about microchips. Nanotechnology will be there, and silica particles will be there. So the researchers working on devices like microchip, where it will be helpful in future to detect the disease before the symptoms appears. And nanorobots can actually circulate in the blood vessels and detect the blood glucose level, and they can supply insulin as and when required. Silica particles can be used with water to reduce the absorption of carbohydrate from the gut. So this future research is going on in these aspects. Like in Australian researchers from the Royal Melbourne Institute of Technology University and University of Sydney, they working on a microfluidic chip, which contains tiny channels and pumps that can precisely control fluid. And in future, this detection kit will be used as a standard test for newborns catching the disease in its earliest stage. So if this microchip will work, it will be easy to detect disease in early stage, and then by using immunotherapy, the disease can be prevented. Nanorobots, your nanotechnology, there was a review article published by Eugene T. et al. In 2021 in Journal of Diabetes Research about the potential of nanotechnology in treatment of diabetic complication, and they concluded that almost all the complications, like from diabetic nephropathy to retinopathy to the peripheral diseases, diabetic foot, can be solved by using nanoparticles like silicate nanoparticles or gold nanoparticles, or by using nanoliposomes or nanocurcumin on the severity of sensory motor polyneuropathy. So there are a lot of research going on in this technology, which they are publishing every year, like 2017, 18, 19, that these nanotechnology can really be helpful in preventing or treating the diabetic complications. And at last, the silica particles, a company Swedish from cigarette therapeutics is working on developing an ingestible silica powder, which can be given with water, and it will interfere with the digestive enzymes and slow down the absorption of cholesterol and glucose into the blood. And they can treat type 2 diabetes and obesity without being absorbed in the gut, or at least they will reduce the pill burden of type 2 diabetes mellitus patients. So to summarize my talk, I would like to say that there are a lot of difficulty in answering the question that are we near the cure. If you ask me, are we near the cure, I will say no. But if you again ask me, are we far away from the cure, then I will say no again, because in the history of timeline of a disease which is known from more than 2000 years, if 10 to 15 years more is required to get cure, it is not far away. But yeah, in present timeline, in real time, it seems far away. And cell therapy is definitely a game changer if our researchers are able to overcome those challenges which we discussed about the site sustainability and supply. And immunotherapy will actually bring the prevention of the disease along with the microchips if we developed in future. And microbiota is one of the interesting area where a lot of research is going on, which will help type 2 diabetes mellitus patient in a significant way. And nanotechnology is obviously the future, along with the artificial intelligence, where a smart algorithm is needed to make devices so smart that it will become user independent. So these are the references to my talk. And with this, I would like to finish my presentation here. Thank you.
Thank you, sir, for giving us a hope for cure.
So are there any questions from the delegates? There is one question in the chat box, sir. What about the pancreas of pig?
So recently, this transplantation is in preclinical stage, where rodent population is being used to successfully transplant the beta cells. Then there is some work in non-rodent population will be required before starting it as a clinical trial. So in that, maybe monkey, dog, or pig pancreas can be used.
Are there any more questions from the delegates? Delegates, if any questions, please unmute yourselves and ask. I think there are no questions from the delegates.
Thank you, sir. Thank you for sharing the vast information on recent updates and giving a hope for cure.
Thank you very much for the patient listening.
Mellitus. I request the delegates to give the feedbacks on CME.
Can any of the delegates are interested to give the feedback? The overview of the CME.
Overall, it was very good, ma'am. Starting recent advances, future targets, are we near to the cure? Everything was very good, and all speakers are experts in their field. I like that pediatric endocrinology part. She started with many case scenarios. we can connect it to the real life. So very well organized one. Thank you for the organizing team and the speakers. Thank you very much.
Thank you, ma'am, for your encouraging words. Any others? Any other delegate who wants to share the feedback?
It was a very good session, especially for the clinical doctors who practice regularly. It was really a refreshing course. If possible, could you all please share the slides over the email?
Yeah, we will ask the speakers. If we get the slides, we will share, Nagamani. Thank you so much.
Thank you, ma'am.
Any other feedback? Anybody is interested?
Hello.
Yes, sir. Please.
Myself, Dr. Rajadnya. I am from Maharashtra. It was a very well organized webinar, I should say. And as I have already mentioned in my message to you, I have congratulated the organizing team that it was a wonderful mix of speakers from different walks of, expertise, like somewhere from industry, somewhere from hardcore academics, clinicians, someone related to online medicine and telemedicine. So it was a wonderful experience. Thank you.
Thank you so much, sir. Thank you, sir, for your encouraging words. Now we will proceed with the vote of thanks. The vote of thanks will be done by Dr. Rajini Madam, the organizing chairman.
A hearty good evening to all. It has been my pleasure to propose a vote of thanks for the CME. My heart fills with a great gratitude and respect to our beloved director, sir, Dr. P.S. Boosreddy, and our principal, sir, Dr. Mahesh Bargundi, who have been relentlessly encouraging us to do such activities, and our medical superintendent, Dr. Rajshekhar Mageri, and our district surgeon, Dr. G.S. Pallet, sir, for giving us immense support. The center of the CME, I thank the eminent speakers who have allotted the precious time to our CME. I thank Dr. Patanjali for explaining us the role of SGLT2 inhibitors as a first-line therapy in diabetes mellitus. Dr. Harsha for elaborating and novel insulins that are available and how to individualize them. And Dr. Arvinder Signal for making us understand the importance of digital therapy to improve the health. Dr. Shaila Panchpure for updating on management of diabetes mellitus in pediatric population. And Dr. Srivastav sir on extensive and compiled information on a newer target and new approaches to the old drugs. And lastly, Dr. Niket Rai for elaborating on entirely newer technologies, newer ways like bioengineered mini pancreas, so that we can hope there is a cure for diabetes in the near future. With this, I thank all the speakers for allotting your time to us. I thank all the delegates for your active participation in all the sessions. Even in the post-lunch session, I was really surprised with your participation. And last but not the least, I thank our head of the department, Dr. Majgi sir, who could not be here with us, but has given me opportunity to organize the CME. And our organizing team, what a team. I've got a very enthusiastic and talented team. I'm fortunate with that. It consists of Dr. Murtyunjay Mirje sir, Dr. Siddhamma, Dr. Namrata, Mr. Rajapaya Desai, Mr. Praveen, and Mr. Rajesh, and postgraduate student, Dr. Dev Sena. I would also like to thank our engineer, Mr. Umesh Patil. And I cannot end it without thanking our clerk, Ashfaq and Aisha. And I thank one and all for the active participation. Thank you very much. Now let's disperse. Thank you very much.